adult. And the correct answer is 206 bones and 12% of the body weight. And
so this question is on common fixity for biopsy specimens. Which is the common fixity for biopsy specimens? Most people have answered correctly. It is 10% formalin. If you are sending in for any rapid procedures which doesn't require the routine processing, you can use normal saline. Methyl alcohol and isopropyl alcohol are usually used for cytological specimens as fixities for cytological specimens. So the correct answer for the fixity for biopsy specimens is 10% formalin. Most of you have done it well. So next question is, which among the following is a low-grade osteogenic sarcoma? Parosteal, periosteal, telangiectatic and small cell. The answer is parosteal osteosarcoma. Again, not much confusion. Most of you have done it well.
the fourth question is, the following conditions occur in metaphysis except. Most of the students has answered it correctly. It's chondroblastoma which occurs in the epiphysis. The fifth question is, all are used for extended curettage except. So, the agents of phenol, bond cement, liquid nitrogen, argon beam, then alcohol, hydrogen peroxide, all are used as an adjuvants for this extended curettage. Whereas proton beam is a charged particle which is used in the radiotherapy. Now we will go to the post test.
Decalcifying agent commonly used. It's 5% nitric acid. That's the correct answer. You can use acids. Acids are the ones who can leach away the calcium, which will help in cutting the bone in a easier way. The others don't have the requisite amount of power to bleach the bone of calcium. That's all. And it's an easy question also.
Osteoid is produced by which cell? That's the question. Osteoclast, osteocyte, osteoblast and mesenchymal cell. The answer is osteoblast. Most of you have given the correct answer. Elastic cartilage is found in which area? Both A and B are correct. Pinna of the ear and epiglottis are elastic organs and they have elastic cartilage within them. Again, easy question. Now next is regarding myelin sheath, which covers the nerves. This is formed by axon, Schwann cell, glial cell, fibroblast. The answer is Schwann cell. The Schwann cells produce the myelin sheath which will cover the nerve fibers in an onion skin-like fashion. Okay, perimysium is a covering of the muscle and it covers fascicles of muscle. Not the entire muscle, not a single muscle fiber or a muscle fibril. It covers the fascicles of muscle, skeletal muscle.
Special stain for Ewing sarcoma is periodic acid shift. PAS is periodic acid shift. This was mentioned in our lecture series. So we don't need the required IHC. We can have a differential if we have a differential diagnosis for Ewing sarcoma, a simple special stain can also give us a clue that this is the correct diagnosis. It was an easy question for most of you. The following is a marker for carcinoma. The correct answer is CK, cytokeratin. The others, vimentin is all for stromal cells, mesenchymal cells. LCA, HMB45 is for the blood precursors. So CK is the correct answer.
Antigen retrieval. This is a step in immunohistochemistry, and we retrieve the lost antigens or the hidden antigens by applying heat, either by using a pressure cooker or a microwave oven. So the answer is C, heat application.
The following radiological signs indicate aggressiveness of the lesion. So in this, the soft tissue extension, Sundry appearance, interrupted lamellar periosteal reaction, all are indicators for an aggressive lesion, whereas sclerotic margin means the bone is winning over the pathogen. So the answer is sclerotic margin.
Fresh unfixed tissue is sent immediately for doing frozen section. This is a true statement.
So pick up the wrong statement. Here the matrix means intracellular substance, that is right. Soapable appearance indicate bone formation. That's the wrong statement in this. And the other two statements, puffy calcification occurs that occurs in cartilage tumor, and the ground glass appearance indicate a fibrous lesion. That both are correct. This was a difficult question for some people. That means the example of tumor mimic. I think most of you has confused between this tumor mimic and tumor-like lesion. Here the tumor mimic, the answer is stress fracture. Enchondroma is a benign cartilaginous lesion, and a fibrocortical defect comes under the benign fibrous lesion, and simple bone cyst is a cystic lesion.
Bowen bone is always, it's abnormal in an adult, but it's not specific for a particular disease. In lots of orthopedic pathology, we might find Bowen bone, and depending upon the situation, we will have to make a differential and identify the lesion. Anyway, it's abnormal in an adult.
Pyogenic osteomyelitis in sickle cell anemia caused by salmonella. Easy question. Chordoma is an autochordal tumor and it's a malignant tumor. Again, easy. All are small round cell tumors except, that's the question, Ewing sarcoma, rhabdomyosarcoma, that is a embryonal and the alveolar variety, and lymphomas are traditionally considered as round cell neoplasms. Even though you can say myeloma also looks like a small round cell, usually it is not included in the differential diagnosis.
Most common tumor of the bone is what we find, this being a cancer hospital also, it's metastasis, and the textbooks also say that it's metastasis, mainly from the lung, colon, extra breast, we find cases of metastasis. The others are rarer compared to this.
The hallmark of malignancy is permeative growth pattern, because even in certain benign conditions you can have cellular atypia. For example, in a callus you can have cellular atypia, and a callus may look like a osteogenic sarcoma sometimes, and cellularity also you cannot really trust it because many of the benign lesions are cellular. And necrosis, you can sometimes get necrosis in certain conditions like giant cell tumor. But permeative growth pattern, that is infiltration into normal tissue, is considered a hallmark of malignancy. This is especially true when we are considering a chondroma and a low-grade chondrosarcoma. there the permeative growth pattern becomes very important when you label a tumor as low-grade chondrosarcoma. Immunohistochemical indicator of malignant transformation in giant cell tumor of bone. You can consider P53 as an IHC indicator. It is not a exactly accepted marker, but still many studies have come up saying that doing a P53 immunostain may help you to identify those giant cell tumors which are likely to recur or metastasize. Maybe after a few more years it will get totally accepted, but still it can be done in cases of giant cell tumors.
Osteogenic cell is, we have discussed it earlier also, it's an osteoblast which produces the osteol. That's all.
So lineage defining first panel of IHC markers. So if you take these markers, the last one is the correct answer because there you have different markers which will tell you the tumor belongs to which lineage. For example, pan-CK, if it is positive, it becomes a carcinoma. LCA, that is leukocyte common antigen, if positive, it tells you that it is a hemopoietic malignancy like lymphoma. CD138 is a marker for myeloma. Desmin is a marker for rhabdomyosarcoma. CD1A for Langerhans cell histiocytosis, and S100 for neural tumors as well as cartilaginous tumors. This is the only panel which gives you a clue to the different categories of tumors that you find in the bone. The others do not give a comprehensive idea regarding the nature of the tumor. So the first panel is the last one.
X-ray is a prerequisite for biopsy reporting and is of paramount importance to a pathologist. It is true, as one of our earlier presentations say, it's the three important areas are the clinician, the radiologist and the pathologist. We communicate well and go hand in hand to reach a primary diagnosis for the benefit of the patient.
I think the last question is I match the following. So the first question is about vanness. Vanness is associated with the rotation blasty. Another person that is associated with the rotation blasty is Winkelmann, who has classified the types of rotation blasty. Now the second question is adriamycin. Adriamycin is associated with cardiotoxicity. The clinical importance is that when a patient comes for surgical excision after a neoadjuvant chemotherapy, if the patient was on adriamycin, most probably he will be on adriamycin in the neoadjuvant. We will have to do a cardiology evaluation before proceeding to the surgery. Now the third question is about radiotherapy. Radiotherapy is we usually use in the case of where we get a positive margin, and also as a palliative method to reduce pain in the skeletal metastasis. Now the fourth question is charged particle. Charged particle is associated with the Bragg's curve. Bragg's curve is nothing but a curve plotting the velocity of the particle against the energy that is dissipated. So a charged particle dissipates most of its energy in its last point of journey. So when we design the journey such that the journey ends in the tumor, most of the energy of that particle will be dissipated in the tumor. Example for this is the proton beam therapy, which is coming as a new fashion. This regarding the charged particle and the Bragg's curve. I think that's the end of this session. If you have any doubts, you can just unmute and ask.
We expect some discussion. Okay. Yeah.
And that question on the panel markers, can you please repeat that again? Regarding markers for the
Panel markers.
Fancy.
CD130, CD1A.
Okay.
That question.
You want a clarification on that?
Which one is
I
what?
Okay.
Yeah, this question. Yeah.
Yeah. Okay. PAN-CK is cytokeratin which is positive in carcinomas or tumors of epithelial origin. Leukocyte common antigen is positive in tumors of hemopoietic origin. Usually, the common hemopoietic tumor that we find in bone is lymphoma. So, lymphomas are LCA positive. Then, CD138. Okay, CD138 is a marker for plasma cell. In cases of multiple myeloma, 138 will be positive. Desmin is positive in rhabdomyosarcomas. CD1A is positive in Langerhans cell histiocytosis, and S100 is positive in neural tumors as well as cartilaginous tumors. So, if you have a bone tumor whose nature you are not very sure about, you can use this basic panel and come to a conclusion what kind of tumor it is. For example, if the tumor is CD138 positive, you can say that this is a plasmacytoma and a myeloma workup can be done. Whereas, if you get a positivity for CD1A, you are dealing with a case of Langerhans cell histiocytosis. If it is PAN-CK, it's a metastatic carcinoma. So, by using these panel of markers, you can try to have an idea about a tumor about which you have no clear indication by usual pathology section. None of the other options do not give a wide panel like this. For example, the first one, the IgG kappa lambda, is useful only in multiple plasmacytoma or multiple myeloma. The P40, P63 are useful for squamous cell carcinoma. So there is no point in doing only markers for squamous cell carcinoma when you do not know what the tumor is. Similarly, the third option is applicable to lymphomas and adenocarcinomas only. Only the last option gives you a panel of markers, each one specific for a specific kind of tumor. Okay.
So these are cases you have already seen, quite familiar to you, but I just read it quickly. 10-year-old girl presented with the pain, distal portion of the foot, 2 months, yeah. Just before that, previous. On examination, there is localized tenderness on the neck of the second metatarsal, and you have already seen the X-ray, and the questions are. So, I think I have presented these 3 patterns in my topic on the X-ray discussion, and this belongs to pattern number 2, where the both defender and offender is having equal strength. So the first question to Ajay Ram, why it is not pattern number 1? Dr. Ajay Ram, please. Is online. Ajay Ram is online. If it is not online, then I have to pass through the question to the next person. So I will be reading, asking the questions in the alphabetic order. So the order I have already read, and Ajay Ram, I think he may not be online. So I pass the questions to Anandu Matthew. Anyway, there may be inconvenience from their side. Anyway, they will be losing mark, that's all. Ankit Chako is the next person. Is he available online? It seems that many are those who are supposed. Yeah. And Ankit Chako, it seems he is not also. He also has not joined. Anyway, Binu Alex is there, it seems. Binu Alex.
Hello, sir.
Hello, good morning. Happy that somebody is joined. So my question is why it is not pattern number 1?
Because the sclerotic ring is less,
Yeah.
and the diabetic lesion seems to be more.
Yeah, exactly. That is the answer. So the pattern number 1, what I feel is there is extensive solid periosteal reaction, and the lesion is very small. But here you can see it is not that small a lesion, and the periosteal reaction is not that extensive. So this is about that. The blood invasion, all these things you have seen, the MRI you have seen, this reports, and the majority has written the correct answer. Regarding the pattern, there was some confusion. So almost all has made the diagnosis as subacute osteomyelitis, and so it does not require any explanation. It's all clear. Now the next question is, what is the most important criteria to reach the diagnosis, in which there was some confusion. Somebody has said it is metaphysis, but that is not diagnostic. What is another, just a simple question. Paidi Amarnath, are you available? Amarnath from Srikakulam. Paidi Amarnath. I think he has joined.
Yes, joined.
Yeah. Are you hearing? Shall I pass the question to somebody else? To the next person? Amarnath is Paidi Amarnath. Anyway, there is no other way. So, Raphael Thomas, you are here? Yeah. So, my question is, somebody has written, there are few answers that it is in the metaphysis. But it is obviously it is not the specific criteria. So, what are, just say, if it were, what is the other metaphysical lesion?
It is not crossing the growth plate. So the growth plate is acting as a constraint for the lesion to cross.
No, the question is, the correct answer is lytic lesion abutting the physis. But there are many people who has written it is in the metaphysis. Is that the most important criteria? What do you feel?
No, sir.
It is not, because there are many other lesions like,
Lesions can occur.
yeah, like what? In the metaphysis, what are the other lesions? Most of them are in the metaphysis only. Osteosarcoma or yeah. So fibro, all many of the lesions occur in the yeah. So almost all the tumors are occurring in the metaphysis. So that is not a criteria. That abuts the physis is something that is rather unique for the osteomyelitis, subacute osteomyelitis. So anyway, I think those who are adding the marks, Binu Alex, I think has got 1 point, and Raphael got another point. Now let us proceed. Now management was written, and many there are, yeah. The management, there are four options. One was antibiotic and keeping the limb elevated. And I give, we thought 60% percent mark was given for that, while CT guided biopsy and open biopsy was not given any marks, and the drainage under Siam was the fourth option, and there are many answers which tells CT guided biopsy, because routinely when we get a lesion like this, this is the dictum to do a CT guided biopsy to make a diagnosis. Here, why that is not given any weightage is because it is such a small lesion, and it is very difficult to get into that small lesion and by a biopsy needle. But at the same time, just opening it, and it is rather sure, as we have already seen, the diagnosis is Tubercular Osteomyelitis. So we are unlikely to have any advantage, and the practical difficulty also to get into the small lesion that is superficial. Why should you use a needle? That is not given. Simple open biopsy also is not required, because if we are opening it, we can try. But that is in general. I have to admit that it is in general against the general guidelines regarding the management of such lesions. The general guidelines is you have to have a biopsy diagnosis, but there are exceptions. These are exceptions. In fact, you can go to the next slide. Though my plan was antibiotic and invasion of the limb and the rest of the part, the surgeon who referred the case highlighted the possibility of viewing sarcoma. So parents insisted on biopsy. In fact, my idea was to give antibiotic because I was rather sure, as almost all the delegates are sure, because their diagnosis was Acute Osteomyelitis. And so it is such a sure diagnosis that we are not going to the classical method of doing biopsy and all. So I decided to give antibiotic and give immobilization and all. But they are not convinced, because the doctor who has referred said there is a possibility of wings. Naturally, they are afraid. So the site was opened under Siam guidance, under tourniquet, cortex over the lytic area opened with a bone owl. A drop of pus came out, sent for culture, cavity urethra sent for biopsy, and next slide. Now I invite the pathologist to describe the lesion. The pathologist will be telling about Dr. Savitri will be telling you about the.
Okay, this is a low power picture of the biopsy that we received. You can see plenty of blue and white structures here. What you see here, the reddish ones are the hemorrhage. In the middle, you can see these blue rimmed pink structures, which has plenty of blue around them. Here also you can see that. These are all bony spicules, and most of them are dead bone. When the bone becomes dead, it takes up a more bluish color. Okay, so these are all fragments of dead bone which is infiltrated by something. Okay, now next. So this is a higher power view, and you are seeing what are the things that are infiltrating into the bone and killing the bone. So these are all inflammatory cells. If you look carefully, you can see that each of these inflammatory cells have an irregular outline of their nuclei. In fact, these nuclei are all lobulated. So the inflammatory cells with lobulated nuclei are the neutrophils, which indicates an acute inflammation. So here you have an acute inflammatory infiltrate extending into the bone and marrow and causing death of the bone. It's a case of bacterial osteomyelitis.
So, what is your diagnosis was the question, and I think vast majority has written osteomyelitis, and Dr. Savitri has beautifully explains the the pathological picture also. I think we can, yeah. So, postoperatively we are given a slab, and this is X-ray taken after 1 month. Now the obviously bone is filling. You can see the periosteal reaction has become more extensive. It has become more solid, and the lesion has become smaller. So that is why the pattern number 2 has changed to pattern number 1. So that is the response. The body is winning. So that is the beauty of it. Now regarding this, any delegates want to ask any questions? Of course, we only active discussion, doubts and the questions will be making it attractive and useful for you. Of course. Anyway, we come to the next. Yeah. Yeah.
This subject of why is immobilization one of the treatment paths?
Immobilization?
Why should we actually immobilize the body?
Yeah, because we have to help the body, help the bone, give rest to the bone. That helps the body, because body has to win. Why? Because if the patient is walking, that is not giving rest to the part. Rest to the part is essential for the healing, whether it be infection or trauma. Why we are giving plaster for there is a sprain? You give rest to the part. It helps healing. So plaster is to help healing, help the bone to heal, help the body to heal. I think that is that answers you. Okay.
Sir, one doubt.
Sir,
you told that you were sure that it was osteomyelitis from the X-ray picture. But the parents had a strong biopsy. So is there any timeline that we can compare to the parents of bystanders that since osteomyelitis will go away, and then we will go for biopsy? Is there a timeline?
Yeah, in fact, I tried to convince them. Moreover, I put a plaster and gave antibiotic and sent them home and think over that. Next day itself they call me. They are very much worried. They may have searched in the internet about Ewing sarcoma and all. So they are really worried. Anyway, things ultimately you get a good case for our CME. That's all what happened.
Thank you.
Okay. Hello, sir. If you are giving antibiotics alone, so how long will it take to give the antibiotics, and how frequently you will be taking something to confirm this only an infection?
Yeah, the antibiotic, the classical teaching is 6 weeks. But I don't think such a small lesion, we have to give 6 weeks of antibiotic. Anyway, you have to assess them clinically by CRP and ESR. And I think 3 weeks will be enough. Repeated X-ray, I think you have seen the X-ray changes after 1 month. If the pus was not drained, it may take longer. So I feel X-ray, more than the X-ray, it is the clinical impression as well as the CRP that may give. I think Jayapras may be able to give you a better answer, because this is a general.
Before I start, I have one question to ask Dr. Savitri. Could we go back to the low power slide, please? To start. Yeah. There you have seen a species of bones and inflammatory tissue. Could you call that at this stage a granulation tissue or just inflammatory tissue?
I will call this a granulation tissue because I can see a few proliferating blood vessels.
Blood vessels there also.
Yeah.
So this is what I wanted to get that answer actually, because you see this is a basics of orthopedic training. A piece of dead bone surrounded by granulation tissue. You can see several pieces of dead bone surrounded by granulation tissue. That's a typical sequester. Understand? So from there we start with the. Sorry?
The video is lost.
Video.
Okay, but are you able to hear me?
No.
Yes, sir.
Ah, right, okay. So the bone infections are difficult to treat naturally, So you require a long period of antibiotic therapy. 6 weeks may be a usual standard, but we may have to extend it up to 3 months sometimes, depending upon the response of clinical, hematological, and radiological response. If the child is the patient is very young, so naturally it is likely to heal better and quicker. But I have seen osteomyelitis recurring even after 60 to 65 years later. So you don't heal an osteomyelitis. If you live long enough, you might see such cases which are actually recurring even after 50 or 60 years. So today, if you ask me, does osteomyelitis heal completely? Well, I don't know. The answer is I don't know, because I have seen a patient, at least one case, where an osteomyelitis occurred after 65 years. So it is difficult to sometimes to answer that how long you have to give antibiotics. The standard regime is up to 6 weeks. You may have to extend it up to 3 months. That's my answer.
Thank you, Jabrash sir. I think we can go to the next.
Can I ask one question?
Yeah.
I would like to ask Binu Alex. Dr. Binu Alex, are you able to hear? You told that the lesion is not crossing the physis. Why it is not crossing the physis? At which age it will be crossing, and at which age it will not be crossing?
Binu Alex, because you only had
previous discussion, you told that the lesion is not crossing the physis, right? So, in which age it will not be crossing? In which age it will be crossing?
Once the growth is over, then
suppose I classify the patients. If I classify the patients into less than 2 years,
there is no physis to cross.
Okay.
Once the skeletal maturity has happened, once the physis is closed, then as there is no physis, then it can cross the.
So once the physis is closed, the infection will be crossing the physis. Can it cross before the crossing of the physis? If I classify the patients into less than 2 years, 2 to 12 years, more than 12 years, in which all age group?
Yes. At that age, I think the vascularity is crossing the physis, the blood vessels is crossing the physis.
Which age group?
So in that case, it can cross the physis.
Which age group?
Exactly, I don't know, maybe around 2 years.
So this is especially important in case of a hip osteomyelitis. Suppose you have got a proximal metaphyseal osteomyelitis of the femur. If the child is less than 2 years, this infection can easily cross the physis and reach the joint.
Yes.
So have you heard of Tom Smith arthritis?
Yes, sir.
Okay. So once the child crosses the age of 2 years, 2 to 12 years, this physis will act as a barrier. So there is less chance of the infection reaching the hip. Okay. So the septic arthritis will be less in the age group between 2 to 12 years. After 12 years, the physis will be closed. So the metaphyseal vessels will be crossing, and again there is chance of septic arthritis. What is osteomyelitis?
It's the infection of the bone.
Itis means inflammation. Osteo means bone. Myela means marrow. So what is osteomyelitis?
Inflammation of the marrow.
Bone and bone marrow due to infection. Which infection is most commonly seen in bone? Which organism? Okay. Suppose it is a 6-month-old baby. What will be the most common organism?
Is it Haemophilus influenza?
Very good. Suppose the patient is just newborn, a vaginal delivery. Which organism will be more common? Raphael?
Staph.
No, which is the commensal in the vaginal canal? Group A, beta hemolytic, streptococcus, and E. coli. These are the two organisms that is more commonly seen in a newborn osteomyelitis. Okay, so suppose the patient is an injection drug abuser. Which organism is most commonly seen? Dr. Sneha.
So, Dr. Sneha, because these discussions will be to everybody, don't only the people in hot seats.
Can you make
yeah.
yourself visible? Dr. Binu, can you make yourself visible? Dr. Sneha.
Yeah,
Okay.
that's fine because
Dr. Shyam.
then only if you see the face only you will be you can be active.
Yeah, Dr. Shyam. Okay, Dr. Shyam, you were visible from the beginning. Can you tell which organism is most common in an injection drug abuser? It is Pseudomonas. Okay. Okay. And
So-
Neisseria gonorrhea is also commonly seen.
So thank you, Dr. Kishore, because this is the way I am planning to, because it's a scenario is just some substance for further discussion.
And osteomyelitis is a very important topic. You
it's
should
important
know
topic.
everything from the definition, etiology, pathophysiology, clinical features. What is the normal pathophysiology? You should know. You should know what is a sequestrum. You should know the definition of sequestrum. Sequestrum is a dead piece of bone seen in a cavity surrounded by infected, unhealthy granulation tissue. So this should be told. This is usually asked for your viva or clinical discussion. So the definition should be very precise. It is a dead piece of bone seen in a cavity surrounded by infected, unhealthy granulation tissue. Okay. How will you differentiate the sequestrum from normal bone in an X-ray? It will be whiter or darker.
White.
Why it is whiter?
Sequestrum will be whiter.
Why it is whiter?
Because the normal decalcification doesn't happen.
Oh, very good, very good. Okay. So the normal decalcification is not happening. Okay. Can you see a colored sequestrum? Sometimes physically.
I think somebody has
Okay. You have to read about everything we cannot discuss today. So again, another important thing is the normal pathophysiology of osteomyelitis that you should know. That is usually asked for your theory or viva. And third thing is the triad of clinical features in acute osteomyelitis. What is the triad of clinical features in acute osteomyelitis?
I think Dr. Sanjeev Kumar, can you answer? Because these questions.
First, you make yourself. Somebody make yourself visible.
Sanjeev Kumar, can you? Yeah. Can you just unmute and answer this question? Yeah. Okay.
Good morning, sir.
Yeah. Good morning. So
I lost my connection just now, sir. Can you repeat the question, please?
We are going through the discussion of the osteomyelitis. We have discussed the case scenario that was given to you, that case of subacute osteomyelitis. Now Dr. Kishore was asking some questions related to osteomyelitis. What was? You can just repeat that question, Dr. Kishore.
Okay, Sanjeev Kumar. What do you mean by sequestrum? Did you hear that question?
Yes, sir.
Okay. So, what is sequestrum?
So it is a dead necrotic bone surrounding with granulation tissue.
You have to tell that there is a granulation tissue. Otherwise, any dead bone seen in a graveyard can be called sequestrum. So, it should be in a living body. Okay. So, what is the clinical features? Triad of clinical features in acute osteomyelitis.
Pain, swelling,
Good.
and fever.
Yes.
And lymphatic
So when a baby is brought to the emergency department with a painful swelling of the lower 1/3 of the thigh with fever, what will you suspect first? Without any history. You have to suspect two things. One is a trauma-related problem, and second is osteomyelitis. And you can have a third diagnosis also. It can be Ewing's also, very remote possibility. So your first diagnosis will be without trauma. Your diagnosis will be osteomyelitis. Okay. So what will you do? You are in the emergency department. The baby is brought. The parents are anxious. What will you do?
Sir, I will tend to will confirm the diagnosis by doing routine blood investigation, sir. Complete blood count, ESR, DRP.
So your first diagnosis is acute osteomyelitis. What will you do? You will be doing, what will be your first action?
Sir, I will send for blood count, sir.
Okay. At the same time, what can you do? When you are taking blood, something can be given also.
Rush to the baby, sir. Rush to that limb, sir.
Okay. When you are taking blood from the limb, you can give something also. What can be given?
Antibiotic.
Which
sir.
antibiotic?
Antibiotic drug is an injection.
Which antibiotic can be given?
The cephalosporin third generation group.
Which generation?
Third generation.
Third generation. Can you mention one third generation cephalosporin?
Triad, sir.
What is the dosage?
10 to 15 milligrams per day.
It is 50 milligram per kilogram per dose. You should know that because you will be seeing babies. You will be in the emergency department. You should be giving antibiotic. So ceftriaxone has to be given, and at the same time you will be drawing blood for three things. One is for the counts, blood culture, and ESR, C-reactive protein. Then what will you do? The baby is having fever, baby is having pain. What will you do?
The antibiotic, anti-inflammatory drugs also you have with antibiotics.
Antibiotic you have already given. What else can be given?
Analgesic, with antibiotic drugs.
Okay, which antibiotic drug you will give for a baby? For a baby, what will you give?
Ibuprofen, the paracetamol.
Okay. So anything else you can be doing? You can give rest to the limb by giving a slap. Will you take an X-ray? Will you take an X-ray?
Yes, sir.
Why? Somebody else can answer.
Actually, to rule out other pathologies, sir, like fracture.
Excellent. So you have to always rule out other pathologies like fracture. You can be sometimes surprised to see an Ewing sarcoma sometimes. Okay. Sometimes there may be a fracture which is not known to the parents, or it can be even a pattern baby syndrome. Okay. So you have to take an X-ray. Okay, I will stop here.
Okay, thank you, Dr. So we can go to the next case scenario.
Yeah. Can I ask from
Yeah, sure.
So in the osteoporotic case, discussing blood cancer, in that case, we will send for biopsy and along with culture and sensitivity also have to send in that case.
Yeah.
The same thing.
Yeah. That is a general rule. Whenever you take biopsy, it has to be, we have to send for culture. When you take culture, take biopsy. That's a very fundamental rule regarding management of both infection as well as tumor. Anyway, we can go to the next case. Next case scenario, please. PowerPoint.
Please switch on your videos. Please.
Yeah, because okay.
Then only the interaction will be happening. Don't be afraid of questions, because it is better to get the questions now than in the examination.
Okay. Now coming to the second case scenario, which was already been sent to you. So this 52-year-old male with these complaints, loss of weight and tenderness, raised ESR, and this lateral view shows some changes about which I was asking, so the diagnosis, I think majority has
Tuberculosis, metastasis.
On analysis of the answers, majority has written the correct answer, which is tuberculosis. So I will be asking, and some of them has written as metastasis, few. And so I will be asking Dr. Shyam Anand from Amrita why it is not metastasis. What is the point against it being metastasis?
One could be from the blood investigation there was late ESR, and other from the X-ray findings, usually in metastasis the pedicle will be the first to be involved.
Yeah.
So, but I that thinking outside, I didn't find anything that.
No, the one point is very correct. That is, pedicle dissection is the diagnostic picture. But what is the specific for tuberculosis? Can you answer that?
So, mainly
what is the commonest site of involvement of tuberculosis? Is it the body or? In the classical case of tuberculosis of the spine, which portion is all in general bone and joints in general? It affects the body or which part? Is the center of the body or which part is affected? The commonest site. I think I have to pass the questions to Shaiju from Thrissur. What is the Shaiju? Are you available, Shaiju? Shaiju from Shaiju JS. Yeah. So my question was, this is the questions that was given multiple. That is tuberculosis was the correct answer, and there are few who has written metastasis as the possibility. And so Dr. Shyam has told why what happens in metastasis. But my question was, what is the site of the spine that primarily affected by tuberculosis? Which portion of the spine is affected?
This is the most common site of it.
No,
That is towards the end place.
Yeah, end place. I think that is right.
it is actually the metaphysis, lower part of the vertebra.
So Jayaprakash sir was saying it is saying.
Well, let me interrupt at this point. Vertebra. Can you go back to the lateral view of the X-rays? That shows that there is actually a disc space narrowing. Disc is not primarily affected by tuberculosis. Tuberculosis per se, tuberculosis of the spine, is actually a tuberculous osteomyelitis of the vertebral body. As is common with osteomyelitis usually affects the metaphysis of the long bone. Vertebra is a compressed long bone. So it affects the the adjacent borders of the vertebra, which you all know that the lower part of the upper vertebra and the upper part of the lower vertebra, they are all developing from the same sclerotome. So that means they share the same blood supply, lymphatic drainage, nerve supply, etc. And tuberculosis is a hematogenous infection. So it affects the adjoining surface of the vertebral body and thereby cutting off the blood supply and the nutrition to the, not the blood supply, the nutrition to the disc, and slowly it eats away. That's why we see that the disc spaces are narrowed. So it affects actually the ends of the vertebral body, not on the disc. So even though we see in the X-ray as a disc space narrowing, disc primarily is not affected by the infection. Understand? So one has to be very clear about it. And the usual question as an examiner we will ask is, why is the adjoining surface of the vertebral body is affected and why the disc space is getting narrowed? The answer is embryological, because they share the same blood supply, they develop from the same sclerotome, and therefore it affects that way. So primary affection of the disc is rare. It has happened, but it is not common. I have come across such primary infections of the disc elsewhere working abroad. That is in actually HIV patients and things like that. They are immunological compromised patients. So you may come across unusual forms of tuberculosis elsewhere. And so some question about the metastasis. Unfortunately, we don't have an AP view of the spine here. We only have the lateral view. The AP view also should show whether there is a pedicular destruction or whether there are any body destruction, etc. That will give us a clue whether that is a metastasis. So that should be your approach. If your examiner asks you from this, can you say that this is not metastasis, you must ask for an AP view. As an examiner, we will definitely accept that view, because you can't blindly give you one lateral view and say that this is tuberculosis or this is metastasis. Okay, carry on.
Thank you, sir, for going deep into that subject. And I think both Shyam and Shaiju has come out with some points. So both of them will be getting half marks. Half points is for this. So this is what from the radiology X-ray we have made out. Loss of height of the vertebra is not seen. Obviously, if it were metastasis, body compression of the loss of height would have been very obvious. At the same time, the joints-wise narrowing, localized osteoporosis. You can see the localized osteoporosis over here, and destruction of the end plates and subluxation of the vertebra. That also is seen if you carefully look at the X-ray. There is some subluxation occurring. So all these are there, but loss of height is not there. So that is a point against metastasis again.
Destruction of the end plate.
Destruction of the end plates, because that's a point in favor of some of Dijoy saying then some has written destruction of the end plates, but that is a point in favor of tuberculosis. So that is the correct answer. Now, how will you proceed? Which of the following is not recommended at this stage? What was the answer?
Open range of course.
And is not recommended. And I think majority has written.
Some
has that should not be done. The question is should not be done. So without any guideline, without any diagnosis, you should not open. It's a very fundamental thing. Presuming that it is tuberculosis is not right, because it is mandatory to have a definite diagnosis in this case, unless the other case where because of practical points that was done. So here it is not at all recommended, not that. And so what we did is we underwent all these things, other things can be done, and yeah. So this is a question which what was too simple a question, does not require any discussion, and you can appreciate the following findings except. So we can see the canal is almost intact. There is no cord compression. I think it is obvious because some people has written it as. What is written? So some has written except, or I don't know whether they have noticed the term except. Some has written psoas abscess and soft tissue extension, which are very obvious. And what I have shown in the round is the psoas abscess, the classical location, which can track down as cold abscess down to the insertion of the iliacus, so to the receptor. So that is very obvious. And coming to the pathology, Dr. Savitri. I think the question is or you can tell later, then you can ask.
Just like in the pyogenic osteomyelitis, in TB osteomyelitis, we see the necrosis. The necrosis will be different. That is, it will be a caseation necrosis. That is a classical word we use for the TB necrosis. And we will be seeing inflammatory cells and Langhans giant cells. That is, the nuclei will be arranged in a horseshoe manner. That is, around the periphery of the cell. And the important point, what we see is we will be seeing the necrotic bone as well as the new bone formation. And these necrotic bones, they harbor they give the bacteria the high resistance to the antibiotics, whereas a healthy bone is highly resistant to any bacterial infection. So there comes the importance of completely cleaning the osteomyelitis cavity. so that the bacteria cannot stay back in the cavity. So if there is any healthy bone, the bacteria cannot stick back to it. And this is the necrotic bone, what we are seeing, and the surrounding area will be is showing the necrosis and inflammatory cells.
And for this question, I think majority has left. And so it is something like this, again they taught in the undergraduate classes, and I think everybody has written correctly.
The giant cell which we see in TB is the Langerhans giant cell.
Yeah. So it is beautifully shown in this slide. With the very, you can tell the characters of Langerhans.
The Langerhans giant cell will show the nuclei which is arranged around the periphery in a horseshoe manner, that is a U shape. That is, at the periphery, the nucleus are arranged in a U pattern. Whereas in a Totten giant cell, it will be at the center. Whereas in a foreign body giant cell, the nucleus will be haphazardly arranged. And the other type of giant cell which you see in the tumors are the tumor giant cells. They are basically made up of tumor cells.
So,
can I add something here?
Yeah.
Yeah, the thing is, the Langerhans giant cell is often the way we name it can go wrong, and somebody can say it is a Langerhans cell. Langerhans cell is something which is normal to our body. Langerhans is wrong. This is Langerhans giant cell. Okay, that's all.
Thank you, Dr. Deepji. So I think everybody has written right. Good. He was put on anti-TB drugs and lesion healed. And after 2 years, I got an X-ray. And you expect the following radiological changes except, and the space regained its height was the wrong answer. And what was the? Some acetylene plaques became more visible. And in fact, as you can see in the next slide, the end plates are becoming visible because it heals. As Debrasio used to say, bone is only one tissue that heals by bone itself. So the other structures, whether it be disc or other structures, it cannot. But here the bone healed by bone. That is why the end plates become quite obvious. I think Debrasio can add something to that. The healing of the...
Well, all of you are going to see tuberculosis in our society. Tuberculosis, we are not going to escape from that. So we should know how to assess patients on anti-tuberculous treatment. We should view them clinically, hematologically, and radiologically. Clinically, normally we should expect the patient should improve his general condition if there has been a weight loss, which has been mentioned in this clinical scenario. So naturally he should gain more weight and his appetite should improve. So those are the general features which show that the disease is slowly abating. Hematologically, naturally the DSR, which was high, should definitely become lower. Radiologically, there should be no further advancing destruction and there should be evidence of new bone formation. These are the two things we are looking for. That means there should be no further advancing destruction and there should be evidence of bone healing. Here you can see that the bone ends which were not visible. In fact, a vertebra which you look on the lateral view is almost like a rectangular box of bone. And you can see the upper border, the sides and the lower border, etc. and the adjoining borders also. So from the X-rays, you can see that the vertebra is regaining its shape. And then the quality of the bone has improved and there is evidence of sclerosis at the adjoining one. This space never becomes normal. It never regains the height. Here in the follow-up X-ray, you can definitely make out the difference between the disc height above, between the L3, L2 and 3. And you can see the difference between the disc heights below also. So these are definite clinical signs of improvement. So these are absolutely essential to say that your patient is improving on your treatment. That's all.
Thank you, sir. So, questions and doubts?
One more point.
Dr. Savitri want to add. One more point.
The three important microscopic features which you have to remember in a TB osteomyelitis is one thing, the caseous necrosis, The second thing, the granulomas. And the third thing, that is the Langerhans giant cells. And the necrotic bone as well as the new bone formation.
Actually, what you see around here, this is a Langerhans giant cell, and you're seeing vaguely nodular areas here. These are the granulomas, which are composed of epithelioid cells. Okay, and when these epithelioid cells fuse together, they form this Langerhans giant cell. So essentially, if you look at the nuclei of the Langerhans giant cell, the nuclei of the Langerhans giant cell is exactly the same as that of the epithelioid cells, which tells you that this is a fused collection of epithelioid cells. It is not mandatory that you find the Langerhans giant cell in a tuberculosis, but definitely there should be granuloma.
Let me add a comment about what Dr. Savitri said. Langerhans giant cells are when the enemy is stronger, you all join together to defend against the enemy. So the enemy here is tuberculous bacilli. The epithelioid cells have coalesced together to form the giant cell. Am I right?
Yes.
Right.
And if you do a spatial stain, if you are lucky enough, you will find an acid-fast bacillus, which is the Mycobacterium tuberculosis bacillus. But unfortunately, after the decalcification and all those processing, in many cases, you cannot demonstrate it. Only very occasionally, we get to see a bacillus actually.
So, any doubts regarding this one? We always welcome doubts. That induces more discussions. Okay, I have, yeah. Dr. Sanjeev, yeah, you are coming out with a doubt.
Sir, in this case, the clinical picture that comes X-ray is enough to confirm tuberculosis, sir. You need to do biopsy, sir.
Yeah, we did a biopsy. You can see the, I shall show.
We have to take a biopsy.
Sir, how can we take the biopsy, sir, in this case?
Yeah, I have shown you, no?
CT-guided biopsy?
Yeah, CT-guided biopsy.
CT-guided biopsy.
This is actually, in fact, this was taken, the CT was taken with the idea of taking biopsy. So, in fact, I thought it was which slide was there, or I don't know whether it is, yeah. So we went like this from here, took passed the needle from here. We use always triggered biopsy needle under CT guidance, and from here I took biopsy, and from the biopsy was proved to be consistent with the tuberculosis. So this is I thought it was there in the. I was under the impression that that slide also was there. No, it was not there. Okay. So that is how you take it. Always, we always do that. So from here, this is source abscess. So if you are taking it, you may not get. So I took from here, from this junction, I took 2 or 3 cores of tissue was taken, and it was sent for biopsy, and it was tuberculosis. So definitely, the treatment depends upon, or the diagnosis depends. The ultimate is biopsy, no doubt about that. Neither the X-ray, neither the blood picture or the MRI, nothing will be a substitute for biopsy. Biopsy is the final answer. Of course, there may be some disparities, but the role of biopsy is always very important.
Empirical treatment of tuberculosis is not indicated right now because we are giving chemotherapy for a long time.
They are all, CBNAT and all are not at all specific. That will not replace the biopsy. Nothing will replace, because we. I don't know whether I have to tell that, because the first, I don't know whether you know that, the first case against the doctors, which made the Supreme Court to include doctors in the customer service that is customer court. The patient can sue a case against you in the consumer court. So that the decision to include doctors in Consumer Protection Act was a case of malignancy of the spine. I think I don't know the exact malignancy, and it was treated by my own teacher who has retired from the medical college service. He's no more, and he empirically put him on anti-TB drugs, and the patient developed a reaction to anti-TB drugs, hepatotoxicity, and it is that case that ultimately ended up in Supreme Court, and that made the judges to include doctors' cases in the consumer protection. So don't, that is not at all justifiable. You will be in trouble. So biopsy has to be taken. No empirical treatment of tuberculosis, at least in this stage, in this era. You may do it 50 years back. That is a different thing.
One more thing, I would like to add another clinically important point. Whenever a patient comes with back pain, you have to think about red flags. So, a lot of people will be coming with back pain. You should remember something called red flags. What do you mean by red flags? So, they will be suggesting 5 diseases: trauma, tumor, infection, inflammation, and Cartilaginous syndrome. So these 5 things has to be kept in mind, and you have to specifically asking the patient for these symptoms, suggestive of trauma, tumor, infection, inflammation, and Cartilaginous syndrome. So then only you will be investigating the patient. So 95% of the patients will not be having red flag symptoms.
So with this, we are ending the 2 cases that is included in reactive. So in this scenario, I will be asking a question to Dr. Savitri. Why it is included in the, why it is termed as reactive? Just
reactive condition is not a neoplasm. So this is a condition of the bone. These 2 are conditions which can involve the bone, which is inflammatory or infective, and it is not a neoplasm. It's a reaction of the body to certain organisms which has invaded it. So it is reactive.
Okay, that are you hearing?
We can't give you tea anyway.
Welcome back. Are you hearing? Rasim, are you hearing? Has anybody joined? If somebody has joined, we can start. Yeah, right. Shyamanand. So we can start because people let the others join. Okay. Shyam, you are hearing, no? Yeah. Okay. So welcome back. So again, this case was presented. Case scenario was given to you. So I need not. It's a lot of details which you have already read. So I am not going to that. And this is all not that pertinent to this situation. What is important is the X-ray picture. X-ray picture and the majority of children myositis ossificans. I think the next question is to Vivekanand Swami. Is Vivekanand Swami available? He is from Coimbatore. Vivekanand Swami, are you available? Vivekananda Swami, yeah. Yeah. Let's see. I don't know. So I think those who are supposed to be in the hot seat is not joined.
They have escaped.
Yeah. Anyway, let us proceed with the way we decided. I think Ajay Ram and Anandu Matthews are not seen, not to be online. And Ankit Chako, it seems we have not seen even now. And the Vinu Alex remains.
It's there.
Yeah. Vinu Alex, yeah. So what made you think it is not osteosarcoma, sarcoma, or hyperactive? What made you think it is myositis?
From the history itself, it's
Yeah, that's right.
This case has a high chance of myositis.
From the
X-ray also shows ossification of the extra-osseous ossification.
Yeah. So it crosses the joints. It is there. Beyond, it goes beyond the joints, beyond the hip joints. Okay. So.
And it is generalized also.
Yeah. Generalized also. Jabra sir, is there anything to tell about the diagnosis that is myositis?
No, I perfectly agree with Dr. Benu saying that it is a patient with quadriplegia. Quadriplegic or paraplegic?
It's quadriplegic.
Cervical spine injury. So
and
naturally,
head injury also.
Such patients are known to be victims of myositis ossificans. The exact reason why that much of bone proliferation occurs in various parts, especially in the hip and the back and spine, we do not know. Are there any present insights why people with head injury develop that kind of this thing? I don't know whether pathologists can contribute something about that. We have no, we have been reading about it, and we see a lot of patients with myositis, especially with the paraplegia and quadriplegia. Are there any new information why such new bone forms in otherwise normal tissues who are patients with neurological damage? Any information?
Anything? Dr. Sure, no, it's okay. So I think Vinu, Alex get one more mark, and so this is the in this one. Some of you have written myositis ossificans progressiva. I think is Amarnath available now? Amarnath? Yeah, he is not there. Then again, it is only Raphael Thomas again. What do you mean by myositis ossificans progressiva? You just tell some of the features of myositis ossificans progressiva, because somebody has written that as the diagnosis. That's why. What are the features of myositis ossificans progressiva? Yeah, it's an inherited condition. Okay. Yeah, as the name indicates, it's a progressive disease. It's a progressive disease, and there are certain points that clinical features that pinpoints to, coming to the toes and all.
Muscles and tendons are also involved in.
Yeah, that's right. That is there in other side also. There is some changes occurring in the toes. I think I'll be asking somebody not in the hot seat. I think Hallux valgus is associated, but more importantly, I think Rasim can answer now. Rasim, are you available? Or Jyotirmai, can you, Jyotirmai, can you answer? Because we have already answered some of the important aspects, so he will be getting 1 mark. But there are certain points which is quite commonly said. Anybody? Not, yeah. Gurumurthy Murugan, can you? Gurumurthy Murugan, can you answer that? Some specific clinical features of myositis ossificans. It has got a short, big toe because of there is only one phalanx. That's what the patient is having only one phalanx, unlike the, so that is a very distinctive feature. So if you are suspecting a case of myositis ossificans, it is a progressive disease as the name indicates. And if you look at the big toe, that is the finding. So that confirms your diagnosis. Anyway, you have come out with some, so you will be getting one mark again. Now that is, and this is what happens, and this is a preoperative photos. You have all seen that, and now coming to the microscopy.
Myositis ossificans. This looks like a very busy picture here. What we are looking for is something called a zonation phenomenon. That means that there is an orderly pattern of sort of a maturation happening. So here what you see, a deeper pink blue, is the newly formed osteoid, whereas you come towards this area, you can identify them as the mature bone. So that zonation is there within a mass, it's a circumscribed mass happening within the muscle. Next slide, please. This is the central part of the lesion, where you find more of fibroblasts arranged with collagenization in between. And if you look, there are areas of spotty calcification, or maybe an osteoid is being developed. So that kind of thing, where the central area is more fibrous, fibroblasts. In the early lesion, there will be edema also here. That's not seen here. Later, in the surrounding area, you find that there is Bowen bone, which is the intermediate area. Periphery, there will be a lamellar bone. And so that central, intermediate and peripheral zone makes make sure that it is a myositis ossificans. Whereas this is about the early part, which might be around 1 month duration. Later on, if a biopsy is taken, what you are going to find is only the lamellar mature bone with the hematopoietic, maybe the hematopoietic or fatty marrow inside. Thank you.
What is the characteristic features and zonation? And you have already explained the phenomenon of zonation.
Yeah. So naturally, the answer should be zonation.
Yeah.
Malignant osteoid is of course here. Malignant osteoid is something that we find in osteogenic sarcoma, not here.
So this is a very important DD of sarcoma, and the zonation is the answer. Now this is postoperative X-ray after resection and after bilateral resection, and compared with the pre and post-op, you can clearly see the joint line, so that he attained some flexion of the hip, and he is able to move about in the wheelchair. He is paraplegic. Now questions and answers. Is there anything you want to ask? You always, yeah. Shyam, Anand.
So in these patients, does breakthrough mistake be very important?
Malignancy.
In these patients, myositis,
Is there any reported malignancy reported? I don't think so.
in the course of breakthrough therapy, will that decrease the progression?
Because regarding the treatment, I think Jayapal sir may be adding, because I have no real answer to that. Yeah, because it is a natural phenomenon. Radiation also has been described. Endometriosis, many aspects has been described. Brachytherapy, I don't know.
It has been tried, but without any much success.
Indomethacin 75 milligram daily is the drug of choice for prevention and also for treatment. And low dose radiation of 700 GYs is also recommended nowadays. And in some centers, I think in Vellore or something, they are giving pre-operative radiation to prevent myositis in certain areas which are prone to develop myositis. For example, elbow. So pre-operative radiation and indomethacin are the two answers you can keep in mind. Is there any name associated with the zonal phenomenon? What will you call dash zonal phenomenon? It is called Ackermann's zonal phenomenon. So in the center you will be seeing necrosis in the malignancy or tumor cells. What will you see in the center? If you take a biopsy from the center of a tumor, you will be seeing necrosis of the cells.
Center will be area of necrosis.
If you take a biopsy from myositis, you will be seeing what? Center, you will be seeing immature cells. So that is called Ackermann's zonal phenomenon. That is important for your examination.
So we come to the next case scenario. This is the details. You already read that. There's the presenting features. And it is some history is there. That is, it is possibly that it is X-ray finding was incidental. And this is the X-ray picture. You have distance and this is the further details. And another view that was taken after a few 3 weeks or so, or 1 month or so. And this is the finding. And what is seen, there is nothing abnormal in the area of the lesion. There is some medial joint tenderness, which is attributable to the recent trauma. So naturally, it is only an incidental finding. Now, what is your diagnosis? And this is the somebody has written enchondroma, and the majority has written non-ossified fibroma, which is otherwise known as fibrocortical defect. For a smaller lesion, we call them as fibrocortical defect. That is not a very definite thing. If it is a larger one, non-ossifying fibroma is more acceptable. But the pathology-wise, it is the same. And so enchondroma, it is a fluffy calcification. That is so classical. Here we can see a definite sclerotic margin. Sclerotic margin that indicates is a fibrous lesion. With the classical description is a ground glass appearance. That is, the normal trabeculae is lost and it become more diffuse or ground glass like. And there is a sclerotic margin. That indicates it's a fibrous lesion. This is a classical picture of a fibrous lesion, which is not aggressive, non-aggressive fibrous lesion. So the ugly site at the lower end of femur, they say it is the attachment of the muscles, like adductor longus is the push of the adductor longus induces such changes in the X-ray. That just happened long back. That remains for a long time. So this is, and it heals. Many times it will disappear over the years. That is the natural course of non-ossifying fibroma. So there is no, it is sclerotic margin, not fluffy calcification. So somebody has written as enchondroma, so that is wrong. There is no doubt about that. Now, how will you proceed? What was the answer like?
MRI. So somebody has a CT-aided biopsy.
No, CT-aided biopsy is not practical. As I said in the first case, such a small lesion and with a sclerotic margin, it's ideal to have a CT-aided biopsy, but you cannot pierce the bone because, as you know, the CT-aided biopsy is being done in the OP under local anesthesia in the CT room as a OP procedure. Though you cannot drill the sclerotic bone. So that is not practical, that is why. So it is better to have MRI for a better diagnosis, to confirm your diagnosis. You are dealing with a benign latent lesion which can be left alone. That is why MRI is a better picture, and you have seen the picture here. All this you have already seen, that is why I am not skipping all this. So again, what is your diagnosis? Non-ossified fibroma was the diagnosis, and they all written like that. Now, how will you proceed? And what was the? Because this is just one example of latent lesions, leave alone lesion. That the lesion says, leave me alone. Don't because I am not doing anything harm to you. It was dictated incidentally. If the girl has not fallen down and took an X-ray, it would have remained there, or it might have disappeared over the years. This is just an example where no treatments, and there are so many examples about which I will be telling you right now. And Jayprakash has anything to add?
Basically, such X-rays, such lesions are detected incidentally. The problem is, if you do not know about that to make confidently a diagnosis that it's a non-ossifying fibroma or a fibrous cortical defect, then you might venture into aggressive investigations like biopsy, etc. So I would suggest, as a beginning orthopedic surgeons, if you are in doubt, better get a second opinion from another senior person, so that you can make confidently a diagnosis that it is a non-malignant lesion and which can be left alone. Most of the time we detect this as a incidental finding. So the more number of cases you see, you will become more confident about leaving them alone. Left alone, it might not be detected until some other reason, some other problem crops up, which makes the patient to undergo an X-ray examination. That's all I wanted to add about it.
Regarding the location, where is it located? Is in the diaphysis or in the metaphysis, relatively? More towards the lesion, the X-ray. Can you show the X-ray? Is it a relatively diaphyseal tumor or a metaphyseal tumor, if it is a tumor? Binu Alex?
It's in the diaphysis.
Okay, what are the diaphyseal tumors you can think of? Which is the most common diaphyseal tumor? It is osteoid-osteoma. What are the other diaphyseal tumors? All of them are small round cell tumors.
Metastasis.
All diaphyseal tumors are relatively small round cell tumors. So what are the small round cell tumors? Ewing sarcoma. Okay, then histiocytoma, adamantinoma, fibrous tumors. So the fibrous tumors come here. Okay, so the diaphyseal tumors are few, only few of them are there, and epiphyseal tumors are also few. What are the two epiphyseal tumors you can easily remember? Giant cell tumor and chondroblastoma. The blasts are seen in children. So the chondroblastoma will be seen in a immature skeleton, and in a mature skeleton you will be seeing giant cell tumor. Giant cell tumor begins with G. So it is the only tumor which is more commonly seen in girls. All others are more commonly seen in males. Okay. So all other tumors are metaphyseal. So if you know the location and the age of the patient, you can make some potential differential diagnosis and you can work around. Okay, that's all from my side.
Thank you, Dr. Kishore. Now, this is an example of bone lesion that has to be left alone. There are many such lesions that need no treatment. Most of them come under tumor-like lesions. What are tumor-like lesions? These are the tumor-like lesions: cystic lesions, simple bone cyst, aneurysmal bone cyst, and the fibrous lesions, fibrous dysplasia, and non-ossifying fibroma. We have seen the non-ossifying fibroma now, and the other important one is eosinophilic granuloma. These are common conditions, but that is hardly understood as a distinct group. I am saying about the general orthopedic surgeons, and this hardly be understood as a distinct group. And tumor-like lesions means these lesions have a appearance and cytogenetic characteristic of a neoplasm, but their clinical behavior support a non-neoplastic nature. It's a clinical behavior. As they are not tumors, basics of tumor surgery need not be applied to them. Unfortunately, these lesions are treated as aggressively as any other bone tumor. That is what is happening now. I strongly feel it is wrong. They need to be treated only if they produce problem or likely to produce problem. So, this is a simple bone cyst in its classical location, that is the upper humerus. You can see the pathognomonic fallen fragment sign. This is the fallen fragment sign, which is considered as the pathognomonic findings of simple bone cyst. This girl was traveling in a bus. Suddenly, her hand into the seat in the front. Driver applied sudden brake. She felt a cracking sound. Orthopedic surgeon suggested curettage and bone grafting. I treated her with arm to chest strapping for 4 weeks. She is totally asymptomatic for the last 9 years. Now, you see few of my cases treated conservatively. You can see the simple bone cyst in classical location. There is a fracture. And then it heals. You can appreciate where there is a fracture, the healing and new bone formation is better. So the present with pathological fracture healed, lesion is healing. Again, presented with pathological fracture. You can see here the fracture has occurred. And at the area where there is fracture, new bone has formed. Another case. A fracture has occurred. Where there is a fracture, there is a healing. So, fracture, this is what is happening. This is a very active boy, conservative treatment as usual. And fracture healed, lesion partly heals, not fully. It is actually a very big lesion. He went back to sports activities and managed to get another fracture. And I was a little upset, but because I myself have warned the parents and the boy that you may get one more fracture. So they are not upset. In fact, I was upset. But the parents were quite confident. I gave a humorous praise. And he went back to sports activities. That is occurred in 2012. This is X-ray of a patient of simple bone cyst I treated without surgery years back when he came for a vacation. He is doing manual labor at Gulf. So I treated him long back when he was a child. And once in a while he thought I can X-ray, and it was a good added to my collection. And it healed. So you see, the area which was simple bone cyst, he has become very sclerotic, very hard bone, and he is doing manual labor. And another case came for follow-up few years, and he opted for a CT scan. You can see some remnants of the lesion is persisting, but the bone surrounding is so strong that it will not produce any harm. So fracture heals simple bone cyst. You need not do anything for that. This X-ray was sent to us 2 years back. We confidently told, the patient didn't come. He sent the case, the X-ray only. We confidently told to leave the boy alone. This is the X-ray after 1 month. You can see in children, the fracture healing is very quick. Story do not end there. There is it is an active lesion because it is it is affecting the physis. So naturally it is active lesion. It will grow. Definitely it will grow. It will continue to grow. The child had another fracture, but it healed in no time. Where there is a fracture, there is healing of the lesion. So when there is a fracture occur, there healing. If there is remains unfractured, then healing will not occur. So this is the feeling had occurred over here. The pathological fracture is not a complication of simple bone cyst. It is nature's method of healing the lesion. That is my concept. The second common site of simple bone cyst is upper femur. Here, because of the anatomical peculiarity, because of the curve over here, we cannot allow it to get fractured and heal by itself because it will malunite, causing limping. So we have to do something, unlike in the humerus, lesion in the subtrochanteric area. So we did a fibula introduced from just above to strengthen the area. We did not remove the abnormal area. So it is a follow-up, it got well incorporated. So interesting case, a 11-year-old girl with a trivial trauma. And you can say, as I am telling about the simple bones, it's a case of simple bones from the X-ray. Classical location, you can see the margins are sharp, so it cannot be an aggressive lesion. Anyway, we took a CT biopsy, but it didn't. It's only blood only. But that, and we again during surgery we did things that also do not give any definite diagnosis, because simple bone cyst is a cyst. Unless you curate out beautifully the lining cells, the pathologists are not able to tell. But if it is some other lesion, you would have got some material if it is a malignant lesion. So we confirm the diagnosis by exclusion, that's all. So what we did is, K-wire is used, so we reduce it, and K-wire is used to guide wire. You can see the serial X-rays. So the fracture has induced healing. It is the fracture that is induced. We haven't put any bone graft or nothing. In fact, we did not open the site even. We went through that and took some curettings for biopsy, which pathologist was not able to do anything. But they did not come out with diagnosis. We did not expect also. But without putting any graft, the nature's healing power, that is, as I said, fracture induces healing. It is the natural phenomenon. It is not a complication. It is the method of healing of the lesion. So we don't do anything for that cavity. See the exuberant bone formation, demonstrating the superiority of biological fixation or implant. So so this is after say 3 years after that. So it is absolutely no problem. And another way of treating simple bone cyst is depometrol injection. A 4-year boy treated by depometrol. Mother is a staff nurse in this hospital issue, and this is how it has healed. So it is not only the fracture, but also the depometrol injection induces healing in simple bone cyst. X-ray after 6 months, see the natural healing and without any surgery. So the pathologist will be able to tell something about the slide. Because as you know, we are not doing any curettings for the simple bone cyst, so we have to take the slide from the net. These are not our things. Because we are not doing anything for simple bone cyst. That is why our pathology lab do not have any specimen of simple bone cyst.
Okay, this is a internet photo of a simple bone cyst. You can see a pink colored cyst wall which does not have an epithelial lining. Many cyst walls have a lining, but here you don't see any lining at all. The wall is fibrous, and in many areas it shows kind of hyalinized or uniformly pink appearance without any cells as such. The cells you identify by the blue dots, which are the nuclei of the cells. In many areas you are simply seeing a pink material rather than cells here. And in some cases of simple bone cyst, you will see degenerated changes like cholesterol, cleft head, hemorrhage, hemosiderin, etc. And osteoclastic giant cells can be there. And if there has been a fracture, new bone formation also can be seen. So there is no real specific feature for a simple bone cyst. So when we get a biopsy from a suspected case of simple bone cyst, we cannot really say, yes, this is a simple bone cyst, but we can say that it is not anything else. We can say that it doesn't look like a tumor or a malignancy or anything. And that is what the orthopedician wants essentially. They want to make sure that it is not any other tumorous condition. So this is simple bone cyst, no very specific features, but you can say this is negative for any tumor.
Thank you, Dr. Savitri. Now coming to the second cystic lesion, aneurysmal bone cyst. Though it is a tumor-like lesion, till recently it was treated by curettage and bone grafting. That was the standard treatment till recently. I used to wonder why aneurysmal bone cyst is aggressive, unlike other tumor-like lesions. I have an answer now. Sclerotherapy with Goldlack and all revolutionized the treatment of aneurysmal bone cyst. made it simple just like all other tumor-like lesions. We can be proud that it started in India and was published by popular international journals. That is about a decade back. I prepared this about a decade back. That's why the slide remains like that. Aneurysmal bone cyst, we have treated 21 cases with the sclerotherapy with the polidacanol during 2011 and 2020, responded to the extent that no surgery required. Cavity did not get obliterated. Don't think that cavity will be obliterated. The wall become thick and disease do not progress. This is showing some of our cases. This is before injection. This is the lesion in the floor of the acetabulum. Suppose we are treating it surgically, how difficult it is to treat, to approach the lesion, very cumbersome. But with this 2 years after the second injection, I did 2 injections. And with this is 2 years after the second injection. It takes time. Don't think that all of a sudden it gets fractured. You have to wait. So this is after the second injection. And this is a 22-year-old female lesion, the scapula, which rolls the scapula. It looks almost like a very aggressive lesion. And this is a few CT cuts and MRI. It is a big lesion. And after 2 months, there is slight relief of symptoms. X-ray did not show any definite healing. Did another polidacanol injection from behind. Initially, it was from the front. Appearance 3 months after the second injection show the healing of the lesion. He has hardly any symptoms now. This is another case. You can see in its classical location. So, as you know, aneurysmal bone cyst occurs in the metaphysis, just like many other lesions or bone lesions. It was treated from other hospital by curettage agent filling with the G-bone. They have treated with the curettage agent with G-bone and had a tissue diagnosis also at that time. But it recurred. It is not uncommon to have aneurysmal bone cyst recur even after the surgery. So we treated with the polidacanol injection and see the result. It has healed. Of course, as I said, the cavity will not get obliterated. The surrounding area becomes sclerotic and it heals. And this is another case in the metacarpal. Yeah, this is a lesion. And it has healed. You can see the healing of the lesion. But the swelling persists. This is another case in 2015. This is MRI. We can see what is known as the fluid level, which is considered as the diagnostic of simple bone aneurysmal bone cyst. Over here, you can see the horizontal line, which is fluid level. In fact, MRI is, as far as the ABC is concerned, the diagnostic test is MRI because it is a cyst. You cannot take biopsy. You can unless you cure out the lining. So many times we can depend on the MRI and the classical picture is fluid level. And I have this is just like any other biopsy. We do it under CT guidance. You locate the area, you just pass the needle, and what I do is you try with the true cut biopsy needle, just like core biopsy needle. And you get repeatedly blood. Again you are getting blood. And then I will be aspirating the blood. And they will be sending for a cell block. And I think Dr. Savitri can say something about the cell block right now.
While taking biopsy here, we get biopsy sample, we get imprint smears. That is, the orthopedician or the radiologist will make touch imprint smears, which we do a cytology staining and try to interpret. It is very often helpful because we get a better cytological detail than the actual biopsy. Very helpful, especially in malignancies. In many cases, we get more pleomorphic cells in the imprint cytology rather than in the biopsy in cases of osteogenic sarcoma, etc. Then another thing is this clot processing. When we get a fluid material, we can solidify that and make it into a biopsy material. We will process it as a biopsy material and get sections, histopathology sections out of it. So that is a clot biopsy. And the advantage of making a fluid material into a solid material and making histology sections, one of the advantages is that if at all we need to do an immunohistochemistry, we can do it on the histology sections. Immunohistology is possible but very difficult in cytology. But if you can make the cytology sample into a histology sample by this method, IHC can be done.
So that is what we do. So we depend the diagnosis, as I said, generally you should have a biopsy, but these are cases which I proceed without biopsy. It depends upon the MRI and depends upon the way the blood is coming. It is simply fills the with a just like the spring coming out from the well. It slowly comes out. And if you go on aspirating, you may aspirate the entire blood that is in the body. So it just slowly fills up your syringe, and that's and sent for cell block, and that findings along the MRI and the cell block we will be expecting a few days later. We make a diagnosis. Then through the same syringe, I will be injecting the polydiagonal injection and putting it to different directions to fill the cavity. And this is the, you can see it is all the years it is getting healed. This is how it looks like. It is, the thickening is persisting, but is totally asymptomatic. The sclerotic bone of the wall has become so sclerotic that the cavities remains. That is the natural theory. So now coming to...
No. Before... Dr. Dominic already mentioned about aspiration of the whole blood volume. I'll share one of my experiences which I had when I was a postgraduate student way back in the 70s. A patient was, I was in the theater as usual with the junior most PG is allocated to do all the dirty jobs towards the end of the day. So someone in the casualty said that there is a patient with a para-articular knee swelling, something like that, to do an aspiration, thinking that it was a hemarthrosis of the knee. So it was around 2 to 2:30 in the afternoon. All the seniors have left. I was left with one nursing assistant and myself. And I started aspirating, doing it on the swelling and aspirated. Aspiration led to some, I filled up one full kidney tray, which is roughly about 300 ml. Then the blood was still not stopping. So I thought I will aspirate some more. Then I suddenly realized I have drawn more than 300 ml of blood. Then I realized I am doing something wrong. So I put a patient on a drip and sent blood for grouping and cross-matching and put a pressure bandage and sent the patient back to the ward. The next day the professor called me and showed me the X-ray of that patient. I have not seen the X-ray before doing the aspiration. You would have aspirated the whole blood volume. That was the comment which he told me. Because when you see that, if you don't see the X-ray and make a diagnosis, if you are planning to do an aspiration for diagnostic purpose, make sure that you don't aspirate more than what you want to know about the diagnosis. But otherwise, the blood will never stop, it will keep on coming. So that was my experience which I wanted to share, because that has happened to me.
Thank you, Dr. Jayapras, for saying such a impressive, you will never forget when you see this case. Okay. Now coming to the slides.
In this picture, you can see several blood-filled lakes. These are all RBCs, so they are blood-filled lakes. And the septa in between these blood-filled spaces show spindle cells as well as osteoclast-like giant cells. So this is an ABC, aneurysmal bone cyst, where you find these lakes of blood. And the septa will show fibroblasts, osteoclastic giant cells, and sometimes even woven bone, newly formed bone can be there. So while interpreting a biopsy of aneurysmal bone cyst, you have to have certain differential diagnosis in your mind. You can have a giant cell tumor. If you get the biopsy material is predominantly from this septa in between, it may look like a giant cell tumor. But you can compare the nuclear features of the fibroblast and the giant cell and come to a conclusion, or at least can have an idea whether it is an ABC or a GCT. In GCT, the nuclei of the stromal cells and the giant cells will be somewhat similar. Even though I say such things, sometimes it is very difficult to differentiate between a GCT and an ABC. And another possibility that you have to keep in mind is that the ABC could be a secondary ABC. You can have secondary ABC-like changes in both giant cell tumor and many other lesions also. So that also has to be kept in mind. And also look at the cells in the septa, see if they look pleomorphic, see if they show atypical mitosis, because telangiectatic osteosarcoma can sometimes mimic an ABC in histopathology. So these things have to be kept in mind before you finally label a case, a biopsy, as a neurismal bone cyst.
Thank you, Dr. Savitri. Now coming to the next question. Name 2 fibrous tumor-like lesions. Shyam Anand can answer if he is available.
Fibrous Dysplasia, non-cervical.
Yeah, we already told that. Anyway, you will be getting 1 point for that. So just make sure that you are listening. That's all. Anyway, you will be getting 1 point for that. So fibrous lesions are fibrous dysplasia, non-ossific fibroma. There are other small fibroma. There are few more. Osteofibrous dysplasia, but these are the commonest. And you need not as a MS Ortho student, you need only these two. Don't go to the rare things. And this is the X-ray and CT and 3D construction of the case of fibrous dysplasia. This flower-like appearance in CT is rather typical of fibrous dysplasia. I followed up of 5 years in this case, was first seen at the age of 12. At the age of 17, she had the same bowing and thickening. Radiologically, there is no obvious change. So these are all leave-alone lesions. Some cases of fibrous dysplasia for my collection, which I decided to leave alone. Some of them have come for follow-up. Some might have gone elsewhere. If somebody had done surgery in them, I think both patient and doctor will be in soup, because fibrous dysplasia is a well-known cause for pseudoarthrosis of tibia. So these are frequently being treated as if they are very aggressive lesions. Don't leave them alone. These are fibrous lesions. This is excellent finding. If you meddle with that, you start meddling with that, you will be in trouble. And the patient will also be in trouble. So in all cases, I take a CT just to make sure. And the appearance, because the appearance, you can see the sclerotic lesion with the ground glass appearance like this. We can see the normal trabecle over here, and here you get a ground glass appearance. So it gives you a more insight into the diagnosis. If there is no cortical defect, if there is a cortical defect, I will be taking a trigger biopsy. I will not be doing any drill and all. Open biopsy is not usually done. So this is the case, not my case initially. They did a biopsy in 2004, and this is the picture, fibrous dysplasia in the bone. And it created no problems. And when she came for she has some swelling, that's all. And she has absolutely no problem. She came for a knee joint problem, just like any other women of this age. Of course, the bowing may be contributing to the osteoarthritis, but that does not mean that you have to get rid of this abnormal bone. If you are starting doing that, you will be in trouble. And this is a biopsy-proved case of fibrous dysplasia. I asked the patient not to undergo any surgery. By frequent phone calls, I make sure that they obey me for the last 3 years, because I am afraid somebody will be doing something for that. If you are doing that, it is a mess. Only thing is that you have to accept the swelling clinically. If you accept that, it is well and good for the patient. And this is a case sent by Dr. Ashok from Trivandrum, knowing my interest in this subject, and sent this photo to me. Krishnaveni, 3 years and 6 years. Bone is fibrous, so inherently weak. As a protective measure, it is thicker, so accept the swelling. So that is why, because it is not a normal bone. So naturally, unless it is thick, it cannot function. So you have to accept the swelling. If you accept the swelling, nothing need be done. And it is our HOD professor, Vijay Prasad, who showed me this case. It was an incidental finding. Somebody frightened her telling about the need of extensive surgery and unpredictable results. Together, we made a diagnosis of fibrous dysplasia, and nothing was done. It is about 1 year back. Recently, she came for review. There was absolutely no change in the X-ray. Then he came to me, and she is quite asymptomatic. If you meddle with, that is what happens, because these concepts are not well established even now. So even a senior doctor has done, and it was not wrong, because these are something which is evolving. He has got this polyostotic fibrous dysplasia where the humerus is more involved. This is what happens. Just remove the abnormal area, put a fibula there. This is what is happening to the fibula. This is getting dissolved. The fibrous tissue encroaches these things, and ultimately it is come to square one. It's as bad as this one, or worse than. So this is the natural history of fibrous dysplasia in a growing child. It's a different in an elderly. If you are putting a fibula, it may remain there in after skeletal maturity. But during growth, it will inevitably invade the graft we have put. Whether it is iliac crest graft or it is fibula, does not make much a difference. And when it comes to peritrochanteric area, this conservatism is not justifiable. It will produce shepherd crooked deformity, if not pathological fracture. So it is difficult in child, but in a patient who is approaching the skeletal maturity, we can do a fibula grafting. That is approaching the skeletal maturity. That is why it remained there. If it were done a few years back, that would not have happened. It would have dissolved. And fibrous dysplasia in children in peritrochanteric area, I have very bad experience, which I'll share with you. So the next person is Shaiju JS. Can you identify any lesion? Shaiju JS, are you available? Shaiju? Yeah. So So can you identify anything abnormal here? Yeah. What is abnormal? What is? Is the entire lesion sclerotic or the margin sclerotic? Yeah, the margins are sclerotic. So we are discussing about what? Shaiju? Fibrous dysplasia. Can it be fibrous dysplasia? What is you feel?
Yes.
It can be. So you cannot clearly appreciate the ground glass, but anyway the trabeculations are not exactly the same. So we can say because of the sclerotic margin and which we may consider as ground glass appearance, you can. So shall you get 1 mark? You can add that. Okay. So over the years it progressed. So it is a 6-year-old girl, and with the growth the lesion is progressing. And they come frequently, and I know it will progress again. If I am meddled with that, then at a particular stage the patient has pain and repeatedly coming. So we had no diagnosis. You have a radiological diagnosis only. So I was a little afraid. So I decided to strengthen it with the fibula. We strengthen the defective bone with the fibula. Then this is what happens. Over the years, the fibula getting dissolved, the tumor wins, the fibrous dysplastic bone wins, and you can see the fibula getting absorbed. This is progress, dissolve the fibula completely, and lesion progress further. This is the appearance after 1 year or so, and ultimately it broke. She came with a pathological fracture. This is what happens over the years. So we have to fix it. By that time he is almost 12 years or so. So I have to fix it, neglecting the proximal physis. There is no other way. You have to neglect the growth of the proximal physis and do a fixation. Of course, I am afraid whether the implant will give support for a long time or you will break the implant. It's a real problem, but there is no other way. And interestingly, she came 2 days back, 23 February 2021, and it is there. The lesion is still there, but the implant is protecting it. So many times I find it difficult to give a definite answer what we have to do in a case of periotrochanteric area in a growing child. I have one more case. Coming to the pathology.
So fibrous dysplasia, there are two components that you can see here. It's a fibro-osseous lesion. So you can see the fibrous bland, fibrous spindly cells in between, and you can see the C and S-shaped irregular bony trabeculae. And this is classically the Chinese letter pattern that you refer to, the irregular woven bone, which is C-shaped, it's irregularly shaped, it's S-shaped. This is the classical Chinese letter pattern. And in between you have the fibrous stroma composed of bland spindle cells. Next picture, madam. Next. And the next thing you're supposed to look for is within the woven bone, is there osteoblastic rimming or not? In fibrous dysplasia, there will be no osteoblastic rimming. This is important because in other lesions, fibroosseous lesions like osteophyte fibroma, there will be presence of osteoblastic rimming. But in fibrous dysplasia, there will be absence of osteoblastic rimming. So these are the two features. It's a fibroosseous lesion. You have a Chinese letter pattern, the arrangement of the woven bone with absence of osteoblastic rimming, and in between you have the bland fibrous spindle cells.
So we took the biopsy. In that case, we took a biopsy before doing the fibula strengthening, and so we get specimen of fibrous dysplasia quite frequently. So this is the question. I think this question is answered. What is the answer like? Okay. So this is the Chinese letter pattern, which is very typical of classical of fibrous dysplasia. That is the answer. Okay. Now another case, exactly same. X-ray of this 11-year-old boy was sent to me by Dr. Abdurrahman from. I asked him to put him on a hip spica. He sent the X-ray to me and asked him, see what shall I do? I said it can be a fibrous dysplasia. That's what I feel at that time. So he said. So I asked him. He's an 11-year-old boy. He is suffering from a fracture. I asked him to put a hip spica. So by conservative treatments, it united. You can see. The fracture united and patient started walking without any problem. So this is after fracture union. We didn't do any surgery for that. To be safe, we put a fibula graft. So we did not have any diagnosis. So for getting diagnosis and to be on the safer side, we did a fibula. But that again, the same happened here also. Ultimately, it broke and we had to do a fixation. And we have to keep it there because the fibula, the plate has to be there. Last but not the least, so we are telling about the cystic lesions and fibrous lesions of the tumor-like lesions. And the eosinophilic granuloma again is a tumor-like lesions. You get what is happening. MRI reported as Ewing's, so that was the report. MRI report was Ewing's sarcoma. So it took an open biopsy. Report came as eosinophilic granuloma. So nothing else was done. This is the follow-up up to 2 months. Lesion fastly. I didn't put any graft or nothing like that. We took a biopsy. When it came as eosinophilic granuloma, I decided to observe. So just referred by litigation. There is a litigation here, and we took a biopsy from here, from this lesion, segregated biopsy. And after 6 months, see the sclerotic ring. You can see the sclerotic ring over here, indicating healing. The sclerotic ring always means the body is winning. By that time, radial epiphysis appeared. So in this way, there is no radial epiphysis. Now it is the patient, the child is growing. That's why. So again, you can see the lesion over here. This is the lesion. And this is that is in 2015, took a biopsy, and by 2018, it disappeared without doing anything. So this is the X-ray over here. There is some sclerosis, nothing much. the treatment protocol for tumor-like lesions, and that is the treatment protocol. Simple bone cyst, immobilization if fractured, with or without lepometol injection. Aneurysmal bone cyst, polydecanol injection. Fibrous lesion, no treatment if fractured, plaster immobilization. Eosinogranuloma, biopsy induces healing. Biopsy induces healing, that is the point. But lesion in peritrochalmic area are exceptions. They need operative treatment without removing the lesion. Without removing the lesion, that is important. You don't get rid of that. You just strengthen that area. In cystic lesion, fibula is of great use. You have seen how the fibula has worked wonders in simple bone cyst. In fibrous dysplasia, implant is better. But shall we do implants at a younger age? It's a question, but still that is better because fibula. It is said that cancellous graft dissolves faster. Fibula takes little more time to dissolve, but implants naturally it will not dissolve. For the last 1 decade, I am trying my best to popularize this concept by presenting in several platforms, including IOCON and recently Asia Pacific Musculoskeletal Tumor Society held at Jaipur, and publishing in the journals. And this is one of my early publications in Indian our Kerala journal. And this is the one reason where Dijo also was a part of the study, enjoying the authorship. And this was again published in a Journal of Bone and Soft Tissue Tumors, where they gave a prominence to that review article by me and Dijo. And so please bear with me for making use of this platform for propagating my message. Just it's a deviation from the topic, but I take a opportunity. Now questions and doubts regarding the tumor-like lesions, small bone cysts, aneurysmal bone cysts, fibrous dysplasia, osteofibrous dysplasia, eosinogranuloma, all these 5 conditions. Any doubts? Yeah.
The old time effect on intake. In some cases, we have talked about the second dose of old time. So, is there any timing regarding by the time we can get the next dose?
About polydecanol.
Second dose.
Second dose. That depends upon the symptoms rather than the X-ray picture. If the patient is symptomatic, you have pain again, then you will be assessing that and doing the because it is very difficult to assess radiologically because the radiology changes takes months. So if the patient is having pain, then that is the criteria where I am because these are things which is evolving and I cannot be very authentic in answering your question. So this is how I do. That's all.
So can it be given to the spine also?
Yeah, we can do it. Just like pelvis. It is very good in spine. You can do it provided, spine. I have no personal experience, but there is no reason for not giving in spine, especially in the posterior elements are, favorite site for aneurysmal bone cysts. So you can rather safe also. It is going anteriorly, this is a real problem. But if you can take a triggered biopsy from the spine, I can very well give polydecanol injection. Because it expands, just like I have told you in the X-ray class, it is what is known as the finger in balloon sign, which is typical. You may be remembering that finger in balloon. So it is just like the balloon gets expanded. There will be a lining which gives a safety of giving injection. It is just like a balloon that has been distended. If you can inject it into a particular point, it will not spread to surrounding area. So it is relatively safe also. Yeah. Yeah, because these are a lot of because what induces the healing is polydecanol is one method. What you do is you break this just like a balloon. So if you break the lining membranes, then it will become less effective. So doxycycline may be doing harm to the damage to the lining cells. Whatever produces damage to the lining cells can arrest the growth of the aneurysmal bone cysts. So there are reports, I know, there are reports. But I am quite happy with the polydacanol, and it is easily available because the gastroenterologists as well as the vascular surgeons are using it, and it is freely available. And as a orthopedic surgeon, you have to do that when you start your practice. I think.
Is there any problem with the escalation of polydacanol?
That is what I said. There is a problem, but we are safe because it is just like a balloon. It will have an intact lining except at the site of injection. All around it is intact. So it is. I can also say it will not produce any problem, but it is safer. It is not that dangerous because it will be contained inside and you are doing it under image. CT guidance. Always do it under CT guidance. Don't inject blindly. Except in lesions like tibia, you can do that without any guidance.
Is there a X-ray readings for fibrous dysplasia? What are the X-ray readings of fibrous dysplasia?
Because if you give a specific lesion, because you have seen the lesions, which may be aneurysmal bone cyst. Say you can see you can take this and so you can go through that. So when it comes like this, so when it comes like that, I made a rough idea of fibrous dysplasia. It may be aneurysmal bone cyst because it is in the metaphasial area. It may be simple bone cyst. That is the idea. But as it is a sclerotic lesion, there is a sclerotic border. We can say it is a unlikely to be an aggressive lesion. From sidewise, we have to think of seriously about the osteosarcoma even because it's a child in the metaphases. Even osteosarcoma is a possibility, but the sclerotic border says that it is unlikely to be an aggressive lesion. That's all. So we cannot say categorically say it is fibrous dysplasia. It may be a benign lesion, it may be simple bone cyst, aneurysmal bone cyst. Fibrous dysplasia comes in the DD. That's all. Okay. So, Professor, anything? Okay.
Dominic sir was referring to latent, active and aggressive. Which classification he is referring to? Or the question is, how will you classify benign tumors? Or how will you classify tumors?
Well, that comes under the staging. Right? It comes under staging. That is common for both benign as well as malignant. And it's named after a very important personality in the field of orthopedic oncology.
It is important to have a systemic approach. You should know the general concepts and you should have a systemic approach to all the orthopedic problems. So one important concept is staging. How will you stage? Can you tell the name of one staging?
Staging is just to go over the
No, name of one staging we use. So that is commonly mentioned one is N-necking staging. Okay, you have got N-necking staging for benign tumors and also for malignant tumors. Benign tumors it is latent, active, aggressive. For malignant tumors it is low grade, high grade and metastatic. So what is the there is an interesting difference in the nomenclature. In one you use Roman letters, in the other you use the Arabic numerals. In which you are using Arabic, in which you are using the Roman letters. Are you getting my question?
Anything we use
for benign tumors you use the Roman letters or no, for benign you use Arabic numerals. For malignant you use Roman letters. So from the picture itself, you can see that it is a malignant or benign. Are you getting my point? Yes. Another important classification is Ajcc classification. American Joint Committee for Cancer. Okay. So the classification uses three things. What are the three things which are used?
Grade, size,
The grade, size, and the metastasis. Here also there is an important thing. There is something concept called discontinuous lesion. So the tumor size come to T3 if it is a discontinuous tumor. Okay, what is the tumor size? The three things you are using are grade, size, and the metastasis. Size can be T1 or T2. T1 means less than 8 centimeter. T2 is more than 8 centimeters. There is something called T3. T3 means it is a discontinuous lesion. So you are having skip lesions. That is the importance of local staging. When you are seeing a lesion, you have to scan the entire bone. You have to find out skip lesions. Are you getting the point? For bone, it begins with B. So it resembles 8. So the size is 8 centimeters. For soft tissue, it begins with S. 5. So it is 5. Okay.
Okay, Dr. Kishore for adding some important points. And now I will be putting a questions to Dr. Vigand Swami. He is available.
Yes, not joined.
Yes, not joined. What do you mean by tumor-like lesions of the bone? If you are hearing, it is well and good. No. So I just because he is not there, it seems he has not joined, seems. So who are available, like say Will John, Joseph John, are you available? Joseph John.
Joseph John India.
Yeah. Then Jyoti Mayal.
Joseph John is here. Joseph John ഉണ്ട്.
അത് അവിടെ ഉണ്ട് പക്ഷേ ഹീസ് നോട്ട് ഓഫാക്കി പോയിട്ടുണ്ട്. ജ്യോതിമായി சொல்லணும் that is yeah. So what you we have a discussion on tumor-like lesions. What do you mean by tumor-like lesions? These are lesions that have both the histological as well as cytogenetic properties of a tumor, but their clinical behavior, so it is not a tumor. That's the answer. Anyway, thank you for answering. Now we come to the benign lesions. So far we are telling about the infections and the tumor-like lesions. Now coming to benign lesions, and in which now coming to who is the Ajay Ram. Not available. Anand, Matthew, because they are the toppers in the written test, so that is why I am calling them again and again. Ankit Chako, they are not seen. It seems normally has joined. Then Binu Alex, what is the diagnosis? Encon trauma. So you are right. One point to you. Okay. So this is So the normal cartilage that is squared out. You can see the normal white cartilage that is squared out. So it's nothing but there is no other diagnosis. So I asked the pathologist to tell about the encon trauma.
So you can see in this low power view a lobular architecture. The tumor is arranged in lobules, and the predominant color is bluish. It's a chondroid matrix which gives this lesion a bluish tinge. And in the chondroid matrix, you can see vacuoles or spaces or lacunae in which the chondrocytes are sitting. Now, if we move to the next Yeah, this is the higher power view where you can clearly make out the chondrocytes sitting in the chondroid matrix. So here there is no hypercellularity, there is no atypia or enlargement of the nuclei. I cannot make out any mitotic activity here. There is no binucleation. So it doesn't look like a aggressive lesion. So it should be a benign cartilaginous lesion, and typically this is the appearance of enchondroma.
So, enchondroma of the finger usually presents as pathological fracture. How will you manage this case? My question is to Amarnath Paidi, is he available? Last time he was not, yeah. Amarnath, are you available? Yeah. So what is it's enchondroma definitely, yeah. How will you manage this case? He presented with a pathological fracture. How will you manage this case? You take a bone biopsy. Okay. Then what about the fracture? You take a bone biopsy. Then how will you treat the fracture then? So are you then purificating the bone? Then what about the fracture? With a so then after the curettage, what will you do? After the curettage, what will you do? Do you fill the area with something? Bone cements. Okay, then immobilization is with what? Body splints. Okay. So that is so you will be using bone cements. Of course, I agree with that. You will be getting 1 point definitely. But I shall enumerate the point. One thing is that such a small lesion. Why should you spend one packet of cement? That's one thing. You can take iliacrus graft or even lower on the ulna graft can be taken. And another thing is that when you are opening that site and putting graft, it becomes so unstable that a simple body strapping may not be enough to stabilize. So the practical way I do is I will say that is the way. Because we make a diagnosis of enchondroma from here. So classical location. So okay, so can you mute, because that may be, yeah. Okay, this is the way I used to do. I say I cannot say that is the way, because that's a more practical way, that's all what I can say. That is, I give a body strapping right now, till the fracture unites. Then do a curettage and bone grafting and do the body strapping at that time. So you treat it with a body strap first time. Then, because it is only because I am rather confident about the diagnosis. If you are not confident about the diagnosis, you have to take a biopsy and all. But this is so classical that you may be justified in doing a wait. You are justified in waiting till fracture unites, because the fracture is a recent development. So you can easily curate out the material and fill it with the bone graft rather than the bone cement. So this is just a practical points. I will not say that is the way, because I have seen cases, similar cases that was treated by curettage grafting along with the fixation of the finger with the gest or some other methods, and that has produced so much of stiffness on review. That is, I have seen some cases that is being done elsewhere, and they treated with curettage bone grafting and the gest fixation or K-wire fixation. That has all produced marked stiffness of the finger. While the method I am using, the stiffness can almost totally avoid it. It's a practical point, that's all. Now coming to another case scenario that you have already seen, arm swelling 2 months back showing increase in size. And this is the X-ray, and because it's a totally not at all a familiar picture, I just for discussion I added that. And naturally, the questions are: is a soft tissue eroding the bone or bony lesion? And a lot of confusion. I think you can because it is something merging into the bone, and there is no scalloping. I feel so it is a bony lesion. Anyway, from the clinical appearance also, it's a bony lesion. That's all what I can say. Because I do not have any strong point to say that there is not a soft tissue lesion, but there is some scalloping on either side. All indicate it is arising from the bone itself. It's okay. Now, which is the wrong statement about this X-ray? And then naturally, this is something which I was expecting. Many of them have written. Sundry appearance is the this is the question. Question again, which is wrong statement. Whether it is fluffy calcification or it is at the metaphyseal diaphyseal junction, or the inner margin is well defined and sclerotic. Definitely, the inner margin is well defined and sclerotic. Margin is sclerotic and inner margin, and another is which is a metaphyseal diaphyseal junction. That is also Israel. The question is whether it is fluffy calcification or whether it is a sundry appearance. That is the important point. So I shall show a classical sundry appearance. This is the sundry appearance of a osteosarcoma. So you can, I think, from the appearance, as if you are giving a shade with a pencil. Pencil on shade it. It is almost like the shading with a pencil. You may be, I think that is, you can understand that. While this is like the fluffy calcification, it is not bone, there is no trabeculations, there is no order. It is just the calcium get deposited in the cartilage. So this appearance is so typical that you can clearly say it is a cartilaginous lesion. So the appearance is so classical, but it mimics, very much mimic a sundry appearance. So interesting exercise, that's why I put it, it's a rare condition, but because of the interesting finding for discussion, I put this. And it is a latent lesion or active lesion. And what was the?
Less than 35% correct.
And some have said a latent lesion because there are some sclerosis on the inner margin. That does not mean that it is not complete, and that you cannot say the margins are very distinct. It is not very distinct. At the same time, it is not aggressive because you can see some sclerosis. So by all means, it is an active lesion. What do you mean active lesion? Active lesion is something that a orthopedic surgeon has to interfere. Latent lesion is something which can be left alone. Aggressive lesion is something an orthopedic surgeon is not supposed to do. It is to be dealt by an orthopedic oncologist. That is the difference. Latent lesion, leave alone. Active lesion, it is for you, for the orthopedic surgeon, general orthopedic surgeon. While aggressive lesion is not for a general orthopedic surgeon, it is for the orthopedic oncologist. So, this is an active lesion, you can, an orthopedic surgeon, general orthopedic surgeon can deal with that. So, the diagnosis is What is the answers?
Osteosarcoma, periosteum.
So before that, so it is a cartilage lesion. That is the most important thing. It is not a bony lesion. The fluffy calcification is so typical. From that alone, we can say the cartilage lesion. It is a cartilage lesion. Now, as it is a cartilage lesion, it cannot be osteosarcoma or osteosarcoma, either periosteal or conventional. It can either be a periosteal chondroma, but osteochondroma also is a cartilage lesion. Now, this is the MRI. You can see it is a well-defined lesion, but at the same time active one. Now, the MRI report features of periosteal osteosarcoma. That is the MRI report. And my question was, do you agree with the diagnosis? And most of them say no. And most of them disagree with the radiologist diagnosis. The MRI may be, anyway, if you see the X-ray picture, you can very well say it is not a bony lesion, it's a cartilage lesion. So that is why I said, if you do not, none of us agree with the diagnosis. So that, why not? Most important point against, yeah, because they have, and I am happy to see that majority have written it as cartilage forming tumor. That, so you understood the difference. So diagnosis is very obvious. There is nothing. There is a periosteal chondroma, which is a relatively rare condition, and such a thing is not that common. I think pathologists will be able to tell. Then why not osteochondroma? The same thing. So it is a cartilage lesion. Osteochondroma is a cartilage lesion. Why it is not? Because osteochondroma is exocysis, where the base is formed by the normal lamellar bone. In fact, the medullary canal, even the medullary canal continues into the outgrowth. So the base of the osteochondroma is normal bone, normal lamellar bone. So which is obviously not there in this lesion. In this lesion, it is not there because there is something wrong there. Otherwise, the cortex would have been continued, just like the as to the pedicle of the exostosis. It's a normal lamellar bone. It can have the medullary canal even. So obviously, it is not osteochondroma. And how will you proceed? And what was the answer? And this is the classical of any tumor. You have to go for a CT biopsy in the present scenario, not open biopsy. And this was how it was taken. And fluffy calcification is more evident in CT. You can see the fluffy calcification over here or this area. So typical, which is more evident in the CT. And about the cytology and other pictures.
This is a cytology smear. These are imprint smears that you get, and you can, when in cytology, you look for the cells and you look for the background. These are two things which are important in cytology. So here you can see the bluish matrix, the chondroid matrix that you can see as a purplish blue color. Next picture. And within it, within the chondroid, the bluish purple matrix, you're able to see something like a bubble with a nucleus inside. Those are the chondrocytes. So in cytology, usually we will never give you that, we would just cut short of saying that this is a chondroid lesion. After correlating with the X-ray and after discussion, we would stop usually short of saying that it's a chondroid lesion. So you can see the bluish matrix and you can see the chondrocytes that with the nucleus, the foamy, the bubbly cytoplasm and the nucleus in the center. Those are the chondrocytes. Again, the same picture giving you how those chondrocytes look like. You can see them, you can actually visualize them in a lacunae. You can see the bluish cytoplasm and the nucleus inside. So those are the chondrocytes. Yet another picture showing you the same, the matrix and the chondrocytes. You can clearly see the cell outline and the nucleus in the center. It's more of a foamy or vacuolated cytoplasm. These are the true cut biopsies. Again, you're seeing the lobules of cartilage, the cartilaginous matrix, and the cellularity inside showing the chondrocytes that is embedded within the chondroid matrix. So you can make out the lobules. Each lobule is well defined. My next picture. And within the lobule, again, you can see the chondrocytes, the clear cytoplasm. That's actually the lacunae. It appears as if it's sitting inside an empty seat. That's a clear lacunae within which you can see the nucleus, that is the blue dot. Next picture. Yet another view, it's a high power view of a chondrocyte. There is no pleomorphism. There is no atypia. I can't see any mitosis. Each lacunae, I can make out one nuclei. So it's a uniform chondrocytes that you can see here. And some of the lobules, the cellularity might be slightly increased.
So, this is the question associated with that common features. What was the answer?
Invasion should be the answer.
Yeah, that is the answer. And what was how was it answered?
Some answered B, no mitosis.
So that is the point. You can explain. More than the mitosis,
yeah.
It is the invasion.
In cartilaginous lesions, it's very difficult sometimes because cellularity might vary. There might be mild pleomorphism, there might be occasional mitosis in a tumor which is growing. So therefore, you have to look at the invasion to the surrounding bony lamellae or to the extra bony invasion. Permeation of the bone. These are the things that make it sure that if it's not there, it's a benign thing. If it's there, it's a malignant thing.
So that is the importance. That is more than the mitosis, the cellular picture. It's the invasion of the tumor into the surrounding determines the aggressiveness. So I want to you see this one. This is cytology. This is something, when we do the true cut biopsy, what we used to do that, you just put it into the slide and just swipe it onto the slide and put it into that preservative. So you simultaneously you will be sending it for cytology as well as for biopsy. So that is why there is a discussion about the cytology where we get the tissue very little. In the cytology, it's only blood, the imprints. The imprints, this is imprints. Naturally, there is a lot of blood on it. It's all RBCs. And this is the tissue, actual tissue. And but from there, they managed to get some idea. But we are sending true cut also. But many malignant lesions, I have seen that in many malignant lesions, this is a benign lesion, you may not be, the imprint may be negative. But in most of the malignant lesions, the cytology, from the cytology itself, we get a very good picture. So here it is a difference. So when we do a critical biopsy, we will be sending the cytology slide, that is imprint cytology also, so that next day I can tell the patient what it is, and I will be asking the patient to call me by phone so that I can give a rough idea what is going on without waiting for the real report. But I will say it is only provisional, but many times when it is a malignancy, for example, sarcoma, you inevitably get a characteristic self in imprint itself. So definitely there is no other diagnosis, osteochondroma. And this is just for, this already you have seen, this is exposed by chromin splitting, already gone, field after that, and X-ray specimen. You can see the specks of calcification. That is the beauty of the X-ray of the specimen. The cartilage become calcified, not ossified. So that's the difference between ossification and calcification. Calcium gets deposited in a half-hazard manner, not in the orderly manner. And this is the you just want to. This is the excision specimen. It was the same picture. I didn't list anything more.
Nothing more. So that's the capsule.
Yeah, you can see the capsule.
That's all.
Yeah. So I think this case was discussed in some of the pathology conferences.
Yes.
So because of the rarity of this condition, it was presented in many pathology conferences, and well appreciated. That's what I feel. But I am pressing it because because not because it's a common lesion, but because of interest in discussion. So after 1 year, it's a benign lesion. But it is an active lesion. Active lesion means it requires intervention, but it heals completely. This is after 1 year, and patient is totally asymptomatic. We have to it's a long incision. There is nothing else. So the question again: Ajay Ram, is he available? No, he was not not available. And Anando Matthews, not available. And Angish Chako seems to be not available. Okay. Binu Alex again. Binu, I think Binu has left or Binu Alex.
Yes.
Yeah. Binu Alex. Chondroma, which is more common? Enchondroma or periosteal chondroma? You are telling about periosteal chondroma now, which is more common? Enchondroma. I think the percentage I am not exact. You can add 1 point. Okay. But say 95 or more number of chondromas are enchondromas, and as far as I remember, except for this one, I have seen 2 or 3, not more than that. And one case which I have seen as presented as Myelin transformation, chondrosarcoma, that was published somewhere. Now, any questions on this?
Sir,
No.
Somebody has to move.
X-ray, you can just repeat. I will not. In the X-ray?
Dr. Binu can mute.
Binu, yeah. So this, that is why it is calcification, not ossification. It is not Sundry. That it is not. It is fluffy calcification. That is why I compared with the classical Sundry.
Dr. Binu, you can please mute yourself. Please mute yourself.
Dr. Rafael, I didn't get your.
Can you repeat the question?
We couldn't hear your question clearly.
No, sir. This is very confusing between an active lesion and active lesion.
That's confusion.
How to differentiate between active and
Yeah, that's right. So you can say the margins, looking at the margin, the periosteal reaction, and the soft tissue extension, these are the things. So you cannot say whether there is a soft tissue extension from the X-ray in this case, but definitely when it comes to the MRI, there is no soft tissue extension. And the sclerotic margin indicates that it is not an aggressive lesion. It is not an aggressive lesion because there is some sclerosis occurring, almost complete. But some periosteal reaction is there. All indicate that it is not a benign, it is not a latent lesion. And the sclerosis indicate that it cannot be an aggressive lesion. So much of sclerosis, it cannot be. Again, other points like there is no extensive periosteal reaction, all these things that indicates that it is not a latent lesion also. So naturally, it is not latent lesion, it is not aggressive lesion. So it must be, and from the clinical picture, it is growing anyway, it is growing. Okay. Now, yeah. Now, this is all you've seen, the 18-year-old boy, and this is the X-ray. and whatever the
Multiple osteochondromic hereditary multiple.
It's almost the same. Only thing is that whether it is hereditary or not. Anyway, everybody has written. I don't think there is any doubt about the diagnosis, whether it is hereditary osteochondromatosis or osteochondroma. It's almost same. Only thing is that if you get a history, or if it is hereditary only. Anyway, from the clinical picture, it is almost same. And Fairbanks, this is multiple epiphyseal dysplasia. These are mainly affecting the the epiphysis. It is naturally arising from. I can ask a question that is Amarnath is. Are you available? Amarnath Paidi. Yeah. So what do you mean by multiple epiphyseal dysplasia? You have heard about the multiple epiphyseal dysplasia? I think.
There's so much background.
Yeah, because I'm not sorry. Anyway. What is multiple epiphyseal dysplasia? Because you are, you cannot, we do not get you, that's why. It's saying that, yeah, I am hearing, we are hearing you, but it is not clear. Anyway, we find it is difficult. Anyway, you will be given 1 mark anyway, because so it is being available. For being available, because you are from so much of faraway place, and we are really proud that people from other places took part. Anyway. So you need mark anyway. Okay, so it affects so it usually osteochondroma affects which portion? I can ask Jodi or Sanjeev Kumar. Usually osteochondroma affects epiphysis, metaphysis or diaphysis. Sanjeev Kumar. Yeah. Sanjeev, is this arising from?
Amarnath is answering right
now. I think Amarnath is answering. So Sanjeev can just switch off. Okay, Amarnath can answer.
Which part of the epiphysis? Amarnath, which part of the epiphysis? It is originating from which part of the epiphysis? You can tell the parts of the epiphysis and tell from which part of the epiphysis osteochondroma generally arise.
Metaphysis. You are telling
his answer is epiphyseal.
Oh, I see. Amarnath, are you hearing? Because you told it is epiphysis. I mean, the osteochondroma is arising from the epiphysis, metaphysis, or diaphysis. Amarnath, can you answer?
Or Sanjeev can.
No.
So much
Amarnath can mute.
Because
Sanjeev can answer.
I hope you are hearing us because there is some problem. Yeah.
And Dr. Sanjeev can start answering.
Amarnath, you can mute. That will be better because
there is some problem with your connection.
Yeah, okay, thank you.
Dr. Sanjeev can unmute and start answering. From which part of the bone osteochondroma arises? Metaphysis. Which part of the metaphysis? Have you heard of perichondral ring of
Metaphyseal junction cell, which is a complication with the medullary cavity of the main bone cell, which is always away from the joint surface. It will grow away from the joint surface.
So clinically, how can you cling your diagnosis? Which clinical sign you can use to cling your diagnosis?
Sir, clinically there is bony heart swelling.
What is meant by Ledger's sign? You told that it is moving away from the joint. So, what is Ledger's sign?
Sorry, sir, I don't know.
Okay, when you run your finger from the diaphysis towards the joint, your finger will be stuck between the tumor and the bone. When you run your finger from the joint towards the diaphysis, there won't be any resistance. You will be feeling a bump only. So that is called Ledger's sign.
So that's a favorite question of examiners. When you get a case of osteochondroma, and naturally they will be asking this question. So that's a favorite question. Okay, we can proceed again. And this condition, autosomal dominant, is a test because the inherited disease.
Which gene is involved? Which gene is involved in multiple hereditary exosteosis? There is something called EXT1, 2 and 3. And if you do a genetic study, because it is a disease that is transmitted through the family, it is good to do a genetic study because you can get the prognosis. If the patient is having an EXT1 mutation, the disease is going to be more aggressive.
Okay, so it's a limited autosomal dominance, and the father and one sibling of the above patient is affected. That is from the history. And this is, I know 8 such families, one of such cases, son and father. You can see both of them in the ward. Of the different indication for surgery, in the case we have described, indication for surgery was all except. So there is a lot of confusion in the answering. And these two are the because naturally it is producing somatocosmetic problem, so that's one indication, and it restricts the movements of the because there is absolutely no pronation supination, so blocking the joint movements, and the tendons are not perfectly moving. So all these are indication for surgery, but somebody has written as fracture of the pedicle. In this case, it is a sessile lesion. If you are seeing that these are all sessile lesions, so there is no pedicle, so there cannot be any fracture. So definitely, fracture of the pedicle is an absolute indication for surgery in osteochondroma. But we are pertaining to this case, there is no fracture, so that is not an indication in this case. And the other is malignant transformation, because this is only 18 years, and the growth is it grows with the tumor. So it is not, you do not expect malignancy. By and large, it is not absolute. It is not absolute in that test. Only after the skeletal maturity, the malignant transformation occurs. That is a consensus. But there are occasional cases where malignancy, especially in multiple osteochondromatosis, there are cases that they are turned malignant even before skeletal maturity. But by and large, the growth of the tumor before skeletal maturity is due to the adolescent growth spurt, not due to malignant transformation. Okay. So this is, you have already seen these photos, and coming to the X-ray,
this actually shows the whole picture. You have that cartilage cap over here. By now you're familiar with how the normal cartilage looks like. There's that hyaline bluish matrix. and then you have the chondrocytes in this in their lacunae. So this is a cartilage cap, and here what's in between is the endochondral ossification and calcification taking place, that you can see here. Here, what's lower down is the bony lamellae of bone, which is separated by the fatty marrow. So it's actually a continuation of the, as far as then the medullary cavity is continuing up and it's getting covered by the cartilage cap. Next slide. This shows the whole view where there's just a rim of fibrous tissue or the perichondrium covering the whole thing also, with the bone, normal bone lower down, the area of merging here, and then you have the cartilage cap.
So it mimics the normal bone.
Growth plate.
Growth plate. So this is just a aberration in the growth. That is why the histological picture is almost same as the growth plate.
The answer epiphysis is not completely wrong, because the lesion actually starts from the perichondral ring of La Corex. So some cells lose direction and started moving in some other direction. So when the child is growing, it is moving towards the metaphysis instead of moving towards the joint line. So the answer epiphysis is not completely wrong. So it usually starts off from the side of the epiphysis and grows towards the metaphysis. The perichondral, have you heard of perichondral ring of La Corex? There is something called a protective layer around the physis. Okay, physis has got different layers. You have got the resting zone, proliferatory zone, and the hypertrophic zone. The hypertrophic zone is again divided into different zones, and all these things are covered by something called a perichondral covering is there, and its function is to protect and also helps in the horizontal growth of the bone.
I think we have a good discussion. If there is any other questions, you can. So we have shown, which is I omitted. There is some bone connecting radius and ulna which was excised because you have already seen all this. I am not. Now coming to a new case, because so far we are discussing case scenarios of the which has already been given to you. Now a few cases, one case, yeah. So this is I think the next person is Shyamanand. Shyamanand, I shall. The question is not yet. That is 15-year-old boy presented with a history of pain over the left knee. He was gradually in onset and progressive nature. Pain aggravated on walking and running and bending forwards while playing. No history of radiation, no history of low appetite and all. And there is a fixed flexion deformity of 5 degrees. There is no effusion, there is no tenderness. Tenderness movements are associated with the muscle spasm. And this is the X-ray picture. And Shyam Anand, are you available?
Yes, sir.
Yeah. Then what is your diagnosis?
I would go for a chondroblast.
Yeah, you are right. You get 1 point. I think it is epiphyseal lesion before the skeletal maturity. There is nothing against the chondroblastoma, and so you are 100% right. Now, next person is Shaiju. For him, in this CT cut, there are specific findings that tells you it is a lesion of the cartilage origin. What is that? Shaiju, are you available?
Spectrocalcification?
Yeah, spectrocalcification, which is, we can, from there itself, we can say it is a cartilage lesion. You get 1 point, add in another. Okay. Now, blood investigations normal, MRI picture consistent with the chondroblastoma. I took a CT scan with the idea of taking biopsy. Considering the healthy hard bone, we abandoned the idea. That is how you take it. You just a marker, and I marker the area, but it is so hard that I thought it better to abandon the idea of serial biopsy. So we directly went to the surgery, and now what is the treatment of chondroblastoma? Vivekananda Swami, are you available now? From Coimbatore?
Samadhi light.
Yeah.
Samadhi light.
Anyway, in between he appeared. That is why I am waiting for him. Okay. Now, Ajay Ram and then Anandandu, Matthew and Agirish, nobody there. Binu Alex, yeah.
Observation.
Binu Alex, yeah. So, what is the treatment of chondroblastoma? Sorry, it's already been given there. It's okay.
Observation.
You are not observing.
Yeah.
Can you observe the answer again?
Actually, the answer is written there.
Actually, just by mistake, this answer is written there. So I shall enlighten about the. If you say observation, is not wrong. But I had two cases that didn't come for surgery, and over the years the lesion disappeared. But that is not an answer. That is just a individual, just a coincidence. Now in Tata DMH and some other areas, they are frequently doing the radio frequency ablation. My question to already Amarnath, are you available now? Let us try whether you can see. Yeah, Amarnath. Amarnath, can you try once more? Yeah. In which condition? My question is, in which condition? Anyway, he's trying, but we find it difficult to get him. So, my question was, in which condition you use radiofrequency ablation? I shall ask to Jerry Gabriel. Are you available, Jerry Gabriel? Jerry Gabriel. Jerry Gabriel is not available. And Navaneet PK, are you available? Navaneet PK? Yeah, okay. So the question was, what was the treatment of chondroblastoma? And these are the answers. And I said, why the section is not, because it is a, why not why the section?
Sir, curative monotherapy
Is enough, because it's a active lesion, not a aggressive lesion. And in which condition you give radiofrequency ablation routinely, usually? Which is the lesion which is treated by radiofrequency ablation?
if it is
Now, which bony lesion is classically treated by radiofrequency ablation? Anyway, it is osteoma. But there are some studies, especially from Tata Memorial, using radiofrequency ablation for chondroblastoma. Okay. So the treatment, as already told by you, is curettage and bone grafting. That's the correct answer.
Can I add something? There are two diagnoses: giant cell tumor and chondroblastoma in the epiphyseal. It can be. Do you have any third diagnosis? If you forget about the age.
Navaneet, can you answer?
Do you have a third diagnosis? Which can be a cartilaginous tumor, which requires a biopsy. That is why we are taking a biopsy. It's a very rare tumor. This clear cell variant of chondrosarcoma.
So that is a classical epiphyseal tumor. Other than giant cell and chondroblastoma, clear cell chondrosarcoma is a DD in epiphyseal lesions. Usual site is upper femur. So we approached the lesion, immediately opened the cavity, took a scoop of tissue, waited for a frozen session, and features suggestive chondroblastoma, proceeded with the curettage, partially filled the cavity with the bone graft taken from the ipsilateral tibia. You can see the ipsilateral fibula, tibia, Yeah, because you can see the staples here. So, and the X-ray taken 1 year after the surgery, patient is totally asymptomatic. It is getting healed, but it is not totally obliterated. And interestingly, I have found that chondroblastoma very irritating tumor. I don't know what is the explanation. The muscles goes into spasm. That's very usual, and it takes some time to recover. So, yeah, I think
before proceeding, could you go back to this? Keep it there. Because you did mention about radio frequency ablation. The answer which you expected was an osteoid osteoma. I have my own doubts about using that for a chondroblastoma, because an osteoid osteoma is just an abrasion around a granulation tissue. You find a granulation tissue in the bone, which is actually the central nidus, which starts irritating and producing a surrounding rim of sclerosis. It's something similar to the formation of pearls in the oysters, because it's an irritant sand granule, which actually lodges inside the oyster, and then produces a pearl around it. So it is an irritation which keeps on occurring for a period of time, and then it heals. So there, probably, we were trained to do en-bloc excision of the osteoid osteoma, especially in the femur or tibia, etc. And we used to run around to get a post-op X-ray of the specimen to make sure that the nidus is included inside the excised specimen, etc. Those days are gone. Today, the interventional radiologists are capable of introducing radio frequency probes to use that to cauterize the granulation tissue and treat the osteoid osteoma for good. But whether that same principle can be utilized in using a cartilage tumor in an epiphysis, I have my own doubts. Only time will tell. So from the postgraduate student's point of view, I would suggest that you stick on to the answer: curettage and bone grafting.
I totally agree with Jayapal sir, because these are all experimental, and as Jayapal sir suspects, it is not scientific. Okay, let us forget about that. Now, I think you can ask the question directly, because something I think pathologists will be telling, but I will just tell what is the histological picture they are highlighting. I think next person is Shyamale. I think Raphael Thomas, chicken wire. Yeah, you get 1 point. Raphael gets 1 point. Okay, the pathologist will explain.
From the name chondroblastoma, we can understand the main histologic points. That is, you can see a chondroid matrix. In this picture, we can see the chondroid matrix in this left upper corner. And the next important histologic picture is the immature chondroblast-like cells. These are the immature chondroblast-like cells with a nuclear groove. There is a coffee bean-like nuclear groove within the center of the cells. So, and another important picture, what should be seeing in the histology is the calcification around individual cells, and that is called as the classical chicken wire calcification. So, from the name of the tumor itself, you can understand the histologic pictures.
So, questions? I think we have a good discussion about this. We can go to the next one. This again something. Yeah, we have gone through that, so I will not go into the details. And this is the finding, and what was the answers? And I think almost all had written osteoma, which is I think is rather classical. Only thing is that there are some other lesions about which we will be telling. How will you proceed? CT scan. It's okay, but in fact, that is yeah. And this is CT scan, and this is the finding. That is. This is a CT scan. We can clearly show the nidus beautifully. But in addition, there is another lesion and I have asked which statement is right, and almost all had correctly answered that. There are two lesions. One on the medial side is the osteoma, and the other one here, over here is most probably a bone island. And I think there is no wrong answer. So it's all clear. And what is the ideal treatment? We have already had some discussion about the treatment. Jebras had beautifully described that radiofrequency ablation, excision, and symptomatic treatment. And this patient came about 2 or 3 years back. So at that time, we are not using radiofrequency ablations at that time. Moreover, it is rather that is the lesion is on the medial side. We can approach GC. So we opted for surgery, and we have discussion already come. That is, as Jebras was saying, we have to remove the entire sclerotic bone, which is now not accepted, because it is the nidus. If you get rid of the nidus, it is well and good. And what is the answer? Yeah. So there was a classical teaching that you have to remove the entire sclerotic bone. But now it is not accepted. If you are removing sclerotic bone is the reactory bone, it is not abnormal bone. It is the nidus that is the culprit. If you get rid of the nidus by chiseling of the overlying thickened bone layer by layer till some discoloration or softness is felt, deepen that area, curated out the nidus completely. That is good enough. This is how you did it. You can see the chisel of the bone, and you get some soft tissue area and just curate it out. And then you get a diagnosis there. This is the picture. I think this is of the same patient itself.
Now, just like Sir said, the classical thing that you see in osteoid osteoma is the nidus. And you can see irregular trabeculae of woven bone. We are all anastomosing irregular trabeculae of woven bone. And if you look into the next picture, if you look carefully, next picture. If you look carefully, the woven bone is rimmed by osteoblasts. You can see those cells which are rimming the woven bone. So you get irregular trabeculae of woven bone which are rimmed by osteoblasts, and in between this irregular trabeculae of woven bone, you will find loose fibrovascular tissue. This is what you see classically in a nidus. And in the periphery, you can see little more thick sclerotic bone. So the nidus is composed of osteoblast rimmed woven bone, and in between them loose fibrovascular tissue.
So the question that is already put there.
The answer to this condition is nidus. The characteristic feature of osteoid osteoma, what you look for is the nidus.
And almost everybody has written the correct answer. So there is no doubt about the question also. And this is immediate post-op, and after 6 weeks, you can see we have made a hole into that to get rid of the nidus. Now we have completed the benign tumors so far. All this are discussed, and now we go to the next item, which is questions and doubts.
Have you understood what is meant by woven bone? What is the difference between woven bone and lamellar bone?
I think Sanjeev Kumar, can you answer the question? What is the difference between woven bone and the lamellar bone? Sanjeev, are you hearing?
Shyam can answer.
Yes, sir. Lamellar bone is mature bone, and woven bone is immature bone. In the woven bone, we see the collagen arranged haplotype.
So biomechanically, what difference that make? Suppose one, I give you two answers. One is anisotropic, other is isotropic. Which one is anisotropic? The lamellar will be having different mechanical property in different directions. The woven bone will be having same mechanical property whenever in whichever direction you give force. So it is isotropic. The one situation you will see woven bone is one physiological condition. Can you tell? A fetal bone. Fetal bone. Then callus. Then in pathological condition, classic example is osteosarcoma, a malignant newborn formation that will be having woven bone. So the woven bone is just like a child. It will not obey the Wolff law. What do you mean by Wolff law? The bone respond to the mechanical stresses given to the bone. Okay, so when you are giving a traction along the proximal part of the femur, that is producing a greater trochanter and lesser trochanter. So that is Wolff law. Okay, have you understood? When it is stressed, new bone will be formed.
I think Dr. Savitri has something to add.
Just a point regarding the histology of the nidus. As Dr. Kishore said, it shows woven bone, and woven bone and osteoid can also be found in osteogenic sarcoma. So when you get a small biopsy of this nidus, there can be a problem in distinguishing osteogenic sarcoma, which is lined by in which the osteoid is lined by plump tumor cells, and this plump osteoblast which rim the woven bone here. So a small biopsy, unless you have a good discussion with the orthopedician and the radiologist and be clear about what they think, there can be a confusion in diagnosis.
Is radiofrequency ablation is a very safe procedure? What will be the temperature in that spot? It will be around 90 degrees. So it should be used cautiously, and in certain areas you should not use that. When you are having new sensitive structures like nerves or vessels around, you should not use.
While doing radiofrequency ablation, we usually approach the swelling from the opposite side. This is actually to protect the soft tissues from the heating probe. So if you have a medial side lesion, you can approach it from the lateral side, so that your heating end of the probe will be completely inside the bone. So that will protect the soft tissues.
So we have shown the films of the cases we have done for radiofrequency ablation, but to avoid repetition, I have omitted them. Now, with this, after this one, we can have the lunch break. This is the already seen this case, and the final details. And many have written. This is the multiple choice question, and many have written simple bones. Simple bones. The reason is, you see, this is the age of the patient is 29, and it is extending into the epiphysis. Simple bones they occur in children, and it is in the metaphysis. So in no way it is not simple bones. And so I think a significant number of people, because if they have an idea of simple bone cyst here, they may. But these are the points to tell that it is not simple bone cyst. Definitely this is JCT only. Then all these things are already written, and unfortunately the doctor who didn't diagnose that, he continues to treat him, and this is all written, already know. So this is the MRI, all this you know. And what specific blood investigation is to be done in this case. CA99. And some of them has written CA99 because of these are markers of liver and colon and all. So we have nothing to do with that. PTH definitely, brown tumor can mimic giant cell tumor, so always have PTH, and the majority has written, but there are few written gone wrong.
Have you understood why parathormone? Yes or no? What does the parathyroid hormone do to the bone? Suppose it is increased. Where is it produced from? It is produced from thyroid, parathyroid. Which part of the parathyroid? Chief cells, parafollicular cells. So it is somehow produced and it responds to what stimulus? Increased calcium or decreased calcium?
Decrease calcium.
Whenever there is a decrease, so calcium is very important for the body. It is finely regulated, especially the ionic calcium. So the moment there is a change in the calcium, body will be responding. So if there is a decreased calcium, parathyroid hormone will be immediately overproduced. What will it do to the body? It acts on 3 regions. One is in the bone, second is in the kidney, third is in the gut. In the bone, what does it do? It wants to increase the calcium in the blood. So what will happen to the bone? The bone will be destroyed. So you will be seeing a lot of lytic lesions. So they are called bone tumors. Okay. So that will resemble a GCT.
Okay, now we shall build investigation, nothing contributory. And what next? Everybody is written, and everybody is written CTR biopsy because this is how you do. And before that, you have to go through the anterior part of the deltoid. This is how you do that. You don't go through the delta pectoral, or this is the site through which you have to go when you take CTR biopsy. Now coming to the histology.
In a giant cell tumor or an osteoclastoma, the tumor cells are the mononuclear stromal cells which you see in between the osteoclastic giant cells. These are the tumor cells, and these are the uniformly admixed giant cells in between the mononuclear stromal cells. The other important features which you see in a giant cell tumor are the degenerative features, just like plenty of histiocytic collections and reactive osteoid formation at the periphery of the tumor. That is again another healing process, what you see at the periphery of the tumor. And the same thing you will see in a patient given denosumab. And these mononuclear stromal cells express the rank ligand, and this rank ligand produces the osteoclastic giant cells and help in the healing process. So this denosumab basically inhibit the rank ligand. So in a denosumab treated patient, you will not see any osteoclastic giant cells, and what you will be seeing is plenty of osteoid and fibrous tissue. These are the osteoclastic giant cells. This is the mononuclear tumor cells, mononuclear stromal cells. When you see the reactive osteoid in a GCT, you should not confuse it with an osteosarcoma. In a GCT, the tumor cells are basically benign, whereas in an osteosarcoma, the tumor cells are malignant. So whenever you see osteoid, you have to see the accompanying cells or the tumor cells which produce the osteoid. If it is atypia, if it shows atypia, that goes in favor of malignancy. If they look benign, they can go in for a bone forming tumor or any other tumor producing osteoid.
Have you understood? The giant cells are not the tumor cells. The tumor cells are the stromal cells.
Okay. So there is no, everybody has written. There is no question. Everybody has answered correctly. And treatments, any difference? So that is the, so there are many who has written extended curettage. And my question is to Shyam Anand, I think he is due there. Why it is not extended curettage in this case? Why we have put wide resection as the correct answer? Why not extended curettage? What is the criteria that you use when you determine the mode of treatment, surgical mode of treatment?
So if it is near the joint,
No, I think the answer is you are not ready with the answer. I think Shaiju can answer. Shaiju? Yeah. Shaiju, what is the criteria? Are you available? Shaiju is not there. Okay. And anyway, I am trying, so I shall go to persons who are available. That is Sanjeev Kumar. Sanjeev Kumar, are you available now? Yeah. So what is the criteria on which you select the cases for curettage and the wide resection?
Thickness and the articular pathways. Thickness of the articular pathways and epiphysis, intact epiphysis.
No. It is, I think. So you feel it is depending upon the epiphysis. If the epiphysis is involved, what is the criteria by which you decide your treatment on?
Sir, in soft tissue expansion, if the lesion is aggressive nature.
Yeah, that is the soft tissue is the answer. If it is going beyond the confines and going to the soft tissues, that is the here you can see it is going all around. You can see it is all going all around. So you cannot say it can be served. Curettage will not do. So that is the reason. Why not curettage? That is the question.
Treatment is based on the stage of the tumor. It can be latent active or aggressive. GCT is one tumor which can be either aggressive or active. Okay. Another tumor, active or aggressive. Another tumor which can be like this is aneurysmal bone cyst. Can be active or aggressive according to the Ajcc classification.
So I shall try Vivekananda Swami once again. I hope he is not still there. Okay, so Ajay and Anandu, Angil, nobody is here. And it comes to Binu Alex again. Binu Alex, are you available? Binu Alex?
Yes, sir.
Yeah. So my question, has radiation any role in GCT? Is it a radio-sensitive tumor? That's my question.
No.
No, but that is your answer is wrong. It is not usually done, but because it produces later malignant transformations, sarcoma changes. But it is very effective. It respond to GCT, respond to radiation. So as it is not being used, I will be giving half mark for that question for you. For Binu, half mark. Then after resection, what are the options? And there are multiple options, and they say all can be used. Almost always say all can be used. So not because of the time constraint, I am not going to that. Then in such an aggressive lesions of the upper humerus, regarding reconstruction after resection, which of the following statement is wrong? Mixed response. So even a very good endoprosthesis can give back near normal function. No. Even the best endoprosthesis can never give back the shoulder function, because it's a very complicated shoulder, and the best is whatever be the process used, the major portion of deltoid actually, the best is modular reverse process, which we have done in this case. It's the first time we are using that. And the classical process is a frail shoulder. We are using that. You can use fibula. I have given empty number of options. All gives a frail shoulder. There is neither stability nor there is any mobility. But the reverse shoulder can produce some stability. And whatever be the process used, if major portion of the deltoid axillary cannot be saved, because after resection, if at all we can save something, it is the deltoid. If the axillary nerve is gone, deltoid also will not be working. So this is something which I want to highlight.
Have you understood the concept? For a shoulder to work, muscles should be there. So the primary muscles are rotator cuff muscles. Okay. If the rotator cuff muscles are acting and the deltoid is also acting, you can use a normal total shoulder replacement. If the rotator cuff is not there, it is not working, only muscle that is helping you to abduct or forward flex is deltoid. Okay, then you will be using a concept called reverse shoulder. The principle is you bring the center of rotation more proximally and distally. So the momentum of the deltoid is increased and it will be more functional. So the deltoid should be acting for the reverse shoulder to work. So that is the indication for reverse shoulder, whether it is tumor or some other disease. Okay, but the deltoid should be acting. If the axillary nerve is not working, you should not give the promise that patient will be able to move the shoulder despite your surgery. Have you understood?
So regarding the skin incision in this case, what is strong statement? And I think many has not. So this is a very fundamental thing regarding the tumor surgery. It is totally different from the trauma surgery. When you approach the upper end of humerus, we go through the deltopectoral. So if you are doing the surgery through deltopectoral, we will be contaminating two components. So you have to go through the anterior part of the deltoid, not through the deltopectoral groove. Let the pectoralis become free. And the encircling the true-cut biopsy, as I have shown here, is again a fundamental thing, because we have to remove the track. If you are doing a resection, if you are keeping the track there, of the track of the biopsy, because as we are doing a true-cut biopsy, it is enough that you remove this much of tissue. But if you are doing an open biopsy, you have to take larger track. But in this case, you encircle the true-cut biopsy. That is a correct, very fundamental thing regarding the this.
So in general, your biopsy track should be longitudinal. Can you violate that rule in some place? Biopsy track in general are longitudinal, except in two regions. Here you can see that the biopsy should be longitudinal. If it is a transverse one, it will be difficult for you to close the skin. Two areas are, one is clavicle. You should use a transverse incision. Another is the scapula. You should use an oblique incision, because your original incision is going to be in that plane. In general, the biopsy should be done by the surgeon who is going to do the definitive surgery. So these are two situations you will use longitudinal incision, transverse incisions.
Okay. So this is after resection, we did a shoulder, reverse shoulder done, and this is the excised specimen with the biopsy tract. You can see the biopsy tract and portion of the deltoid that may be contaminated by the biopsy. You can see the skin here. So we remove the specimen along with the biopsy tract. That's very important, very fundamental in tumor surgery. And post-op, what is that? Join the GCT. I think because it is a locally aggressive lesion, most of the cases can be treated by extended curettage and bone grafting. When there is extensive soft tissue involvement, wide resection is the rule. Now, this is the article, because everybody is depending on Campanachi, but myself and Dr. Kishore has written an article which has been published both in the Indian journal as well as Orthopaedic Surgery, which is a published index journal, where we have laid down some principles, because that has not been well accepted. As exam going students, better forget about that. You confine yourself to Campanachi. That is 23-year-old male presented with the pain over the wrist, right wrist, severe trauma 4 months back, was on Ayurvedic treatment for the last 4 months. As the pain did not resolve and was associated with the progressive range of movement, restriction of wrist and appearance of swelling for last month, consulted orthopedic surgeon and was investigated. And next question is to Raphael Thomas. What is your diagnosis? The age of the patient is 23, okay, and this is the lower and the radius. Is the simple bone cyst. Where do you detect occur? Is in which area? Epiphysis, metaphysis, or diaphyseal? Raphael. Yeah, okay, Raphael. So, what is your diagnosis? Is it in the metaphysis or diaphysis or metaphysis? Epiphysis? Or what is the appearance? Classical appearance? All lead to what? Only one diagnosis. What is that?
Muted.
You are mute. Yeah. Yeah. So, what is your diagnosis?
Sir, it is a osteomyelitis. It can appear in the.
Okay, so you shall pass the questions to Shyam Anand. What is your diagnosis?
Sir, it is a cancer tumor, sir.
Yeah, everything fits into the diagnosis of giant cell tumor. There is osteomyelitis, again it is a metaphysis, Ajcc is not usual. Simple bone cyst, again the metaphysis. This is not the age. And the classical, you can see the soap bubble appearance, which is not that common, but it is here. That is why the case was kept. So, Raphael will not be getting mark for that. Shyam will be getting 1 mark. Okay. And this is which grade? Kaminachi grade. And Shyam can answer. Shyam, Kaminachi what? What do you feel?
This is grade 3, sir.
Yeah, grade 3. Where soft tissue extension is obvious. Okay, Shyam get 1 more mark. Okay. And this is the Kaminachi's description, and you already know that, so I am not going to the details because we have cases to discuss. And this is the MRI which shows it is soft tissue extension. MRI helps in this case by following points except. So the Shaiju, are you available? 5.0. So Binu Alex, what is your MRI helps in this case by the following points except. Binu, yeah. You can take time and answer. So one is to make a definite diagnosis, to plan the surgical approach, to know whether the vessels and nerves are involved, and to determine the length of the section, to know muscles that is involved so as to include the resected specimen. So these are the ideas of MRI, but in which one? In one thing it is wrong.
To make a definitive diagnosis.
Yeah, that is right. So that is a fundamental thing. X-ray helps to make Binu gets 1 point. So X-ray helps in diagnosis much more than the MRI. MRI is for planning surgery. And unfortunately, surgeon did the open biopsy instead of CT biopsy, tuber biopsy, which was the gold standard now. And following all the problems that the open biopsy was created, in this case, except, I think Raphael can answer. That is, you can see the scar. The long scar that has to be excised along the specimen. A surgeon has gone through the flexor carpi radialis. That content has to be sacrificed, and specimen was not adequate, which is the wrong statement. Raphael. One is a long scar What do you feel? It is right or wrong statement?
It's created in the long scar has to be excised to the specimen.
What is the problem? Following the problems. Except. So, there are two problems which is real and one problem which is not real.
That's the flexor carp.
This problem with this collection, I think. Yeah. So can you make out what is the problem?
Specimens are Osteogenic.
Actually, anyway, you are supposed to answer only when you ask for. Anyway, Rafael was trying it just wrong, and Sham was correct, and you can add Sham. So specimen was not adequate because you see, when you open, specimen will be adequate naturally. So in this case, what happened is long scar, when there is a open biopsy, it is long scar naturally. But in this case, the particular point I want to convey is when a trauma surgeon do a fixation over the radius, they are used to go through the flexor carpi radialis. You may be seeing the cases where you are going through the flexor carpi radialis and approach the fragments. But the tumor surgery, the concept is different. You should not go through the tendon. In this case,
the muscular plane.
Yeah. So only because of it has gone through the flexor carpi radialis, that has to be sacrificed. So the approach of the tumor surgery is different from the trauma surgery. That's the point I want to highlight. So surgical plan of the tumor en bloc excision, ulnar transposition, and wrist arthro disease. This is we are doing routinely. And now I shall ask Shaiju, what is the other option after resection? What is the classical method of reconstruction? So Shaiju is not available. Shaiju? Not available. It's not available. Okay. Binu? Yeah. What is the classical way of reconstruction?
Otherwise, we can use the fibula head.
Fibula head, upper part of the fibula, not the head alone. So you can, Binu, get one more mark. Okay. Now this is the scar, and we have to excise the scar like this, and this is the. So we have gone approached it both dorsally and ventrally. Because forearm, this part has got radial artery as well as ulnar artery. That is why we are doing that. It is not a very well-known method. And this is the perioperative photos. You have to excise the biopsy scar along with the tendon. Tendon has to be sacrificed. This is the flexor carpi radialis tendon. The tumor infiltration of the flexor carpi radialis sheath is very obvious. And this is the excise tumor en bloc, radius, the articular surface can be seen. And there is a break in the cortical articular surface. But anyway, joint was not contaminated. And this is the scapholunate complex. We can see the smooth articular surface and the ulnar styloid here. And this is how you fix it. So we fuse the wrist. So this is accepted. This is the ulnar translocation for excision of the Commonest grade 3 giant cell tumor of the distal radius. And it has been described much earlier, but it is people from Tata Memorial that has popularized it. So I am many times get opinion, and I have some short training also in Tata, so many times I follow them. This is the operative technique. The radial lesion was excised en bloc with the surrounding soft tissue and pronator quadratus muscle in order to avoid contamination of the remaining tissue in the tumor. And after division of the adjacent ulna at the appropriate level, the distal ulna with its retained muscle attachments are transposed into the bony defect denuded of the cartilage and opposed to the cartilaginous surface of the similarly prepared scaphoid and unite. Before transporting the ulna, care was taken to ensure that periosteal sleeve has been completely divided around the ulna at the level of the proximal osteotomy. So these are points we have to do. Now it has become very standard. The classical answer, replacement with the upper fibula, has to be changed. Because a lot of papers are coming with this method. The problem is that when we replace the upper part of the fibula with the fibula, when we had a wider section, you cannot have a stable joint. Though they say we can get a good wrist joint, it is almost always impossible because we are removing the lot of soft tissues. So once you remove the K-wire, it is subluxate. This is we have seen many other cases, not all cases. Without disturbing the retained muscle attachment, the transverse ulna was aligned with the radius and second or third metacarpal so that the forearm retained full pronation and supination and when it is internally fixed. So we retain the forearm movements, but the wrist joint is arthrodesed. And this is what we do the postoperative. Now, I think we have a good discussion on the GCT. So we go into the next case. This has already been discussed, so we can quickly go through that. 24-year-old female. This is something which always looks like GCT, and people have written as GCT, most of them. Yeah. So this you can say the classical soap appearance is seen, and it is in the metaphysis. So the other questions like ABC occur in the metaphysis, and secondary deposit will not have this soap appearance. Chondrosarcoma, again, it is the Spectral Calcification about which you have described many times. So I don't think there should not be any reason for telling any lesion other than GCT. It is only GCT, but it turned out to be something else later. But that is a different thing. When you say something from the X-ray, it is nothing but GCT. Chondrosarcoma it turned out to be, but there is no spectrum of calcification. And the MRI was taken, and there is some problem. That is just a fundamental question whether it is T1 or T2. And everybody has written correct. It is a T1 because the fat is white and the marrow is replaced with the tumor tissue. Very obvious here. And on analysis MRI, there is a strong point against GCT. What is that? So when you analyze the MRI, from that you can say there is the correct answer is. So the correct answer is scalloping of the cortex by the tumor, but margins are well defined. That is not very not against GCT. It is epiphysis, that is false. And soap appearance is not typical. Actually, it is typical. So against GCT, the scalloping as seen in the MRI is not very not seen in the on the GCT. Then how will you proceed? Open biopsy, core biopsy through the deltopectoral and core. In this case, deltopectoral should not be there. So that is what I said. The trauma surgery and tumor surgery differ because of the planes. If you are going through the deltopectoral groove, naturally it will be contaminating both the deltoid as well as pectoralis. So always go through the anterior portion of the deltoid so that only deltoid is contaminated with tumor. So this is a fundamental thing. Then this is how we do. We go not to the deltopectoral. This is the deltopectoral groove over here, not here. It is covered only with the deltoid. This is the brachialis coming over here. Don't contaminate brachialis, pectoralis. This pectoralis don't. So go through a cortical defect seen here and pass the needle like this. This is how you do the biopsy. And this is the biopsy specimen which I have shown you. And this is the microscopy. And to our surprise, it was. So we are expecting GCT, nothing other than that. We are rather sure that it is GCT. but unfortunately, not unfortunately, I cannot say it is unfortunate. It is a total surprise for us. But you can tell.
Okay, so instead of the typical giant cell rich picture that was expected, what is found here in the true-cut biopsy is a chondroid neoplasm. There is a blue chondroid matrix. There are chondrocytes sitting within lacunae, not much of pleomorphism, but occasional lacunae show two cells, which again is quite possible. From this we can just say that this is a chondroid neoplasm because it is a small biopsy and there is not much of pleomorphism. It could be a chondroma or it could be a chondrosarcoma, well differentiated, we don't know. But based on this chondroid neoplasm, we will stop at that.
In fact, I have presented this case because of the stage appearance in the X-ray. One of the in Kerala, that is KOI conference in the tumor session, and they were delegates, panelists from the Tata and many that is from Ahmedabad and all, from Bangalore and all, but all unanimously called the diagnosis in X-ray as DCT only. So and they said we cannot believe the pathology report. Then I said I had the diagnosis even by retrieving the material. When I retrieved the material from the true-cut biopsy needle, it was chondroid. I have no doubt. This is you can know.
The resection.
This is to This is after the curettage. We did curettage, and this is the
This is the bigger specimen. This again shows a chondroid neoplasm. Here now we have two possibilities. One is a chondroma and the enchondroma, and the other is a well differentiated chondrosarcoma. Okay, now in this particular picture, you can see that there is increased cellularity. Even though there is not much pleomorphism, the cellularity appears to be increased. But otherwise, it could still be a chondroma. So how do you differentiate between a chondroma and a chondrosarcoma? Now, the best way when we have an issue is to see about the permeation into normal bone. Now, if you look here, you can see that these are bony trabeculae, and this chondroid neoplasm is seen to permeate into this normal area. Here also you can see it is permeating here. Okay, so even though this could be cytologically a chondroma, its behavior is not that of a chondroma. It is very clearly permeating into the in between the normal bony trabeculae. So the diagnosis here is well differentiated or grade 1 chondrosarcoma. Now this is a different picture we got from the internet. This is a less differentiated chondrosarcoma. Okay, here the chondroid appearance is much less than the previous picture, even though we can still make out it as chondroid. And in this picture there is no confusion. This is not an enchondroma at all. Here, if we had got this picture, we would have straight away said it is a chondrosarcoma. But in the previous picture, the only factor which favored chondrosarcoma over an enchondroma was the permeation of the tumor into the normal structures.
So how will you proceed? And what was the
wide resection PET scan?
Wide resection PET scan. Actually, ideally you have to take a PET scan because the grading of the cardiac lesions is very difficult microscopically. So if there is a high uptake, we consider it as a chondrosarcoma, so that we have to do a wide resection. If it is a low grade one, then extended curettage is enough. So both are correct. Actually, PET scan can be is to be done ideally. But considering other aspects, many aspects, we decided to do an extended curettage, and this is how you do. You say acromia. You have seen that photos, so I am not repeating that. This is cavity curated after the cavity after extended curettage and curated material. It is not like GCT obviously, it is controlled material only and is filled with bone cement. You can see the bone cement that is filled that area. And ultimately the kinema's chondrosarcoma grade 1 to our leaf. If it were grade 2, what we have done is not justifiable. So this is a problem with the cartilage lesions. Very difficult to grade them, whether it is enchondroma, grade 1 chondrosarcoma, even grade 2, all is a spectrum. And the treatment varies between curettage and wider resection. Is the reason follow? Anything you want to ask about this case? Shyam?
Sir, in this patients, for filling the cavity, bone cement, can we use bone cement in such patients?
Bone cement or bone graft? That is that was your question.
Yes, sir.
Now we have found that chondrosarcoma is not that much, but the GCT, in case of GCTs, we have a extensive study, and in fact it was a thesis for our MS student who has just passed out, and it is found that we have the study was on recurrent GCT, and we had a fairly number of patients also with the recurrent GCT. And recurrence was 8% in bone cement, while it is 11% in graft. And there are many other factors because we can pick up early. Many things are there. And the problem, the doubt was whether it will produce osteoarthritis. And there is no in our study there is no marked change in the osteoarthritis occurrence. There is no serious problem of osteoarthritis, especially in the knee. That is the area. So bone graft, it is the bone cement is becoming more and more popular in the field of orthopedic oncology. That is well accepted, and it is easy also because less morbidity for. So you can, when you are practicing, you can very well use bone cement rather than bone graft. Okay. Now again, a case which I have seen, 6-year-old girl, mild trauma, X-ray taken here. But yeah. So there are questions. The answers you can ask. So there is no simple bone cyst starting in the So nobody has answered simple bone cyst. It may be osteomyelitis, it can be osteosarcoma, even sarcoma also. But many features like Shyam, can you tell what are the features? I think there is a question. Yeah. Points against osteosarcoma are age is not typical. So that is the only feature. Femur is the common site, and lamellar periosteal reaction can be very well seen, appreciated in this one. This is the classical lamellar periosteal reaction because the tumor is coming out. It is pushing the periosteum, and periosteum is trying to contain it. That is how the lamellar periosteal reaction is there. And this forms the Goldman's triangle also. And you can hear also there is lamellar periosteal reaction. So it is there. There is no doubt. And the site is typical. It is typical. Age is not typical. What is the age group? Shyam can say. Shyam, what is the age group of osteosarcoma?
So it has a bimodal distribution.
Yeah, bimodal. Yes, though Paget's is bimodal occur in Paget's. That is in Paget's can occur, but in our country, Paget's is so uncommon. We have cases, 2 cases of osteosarcoma or Paget's. But by and large, in our country, the first mode is, what is that first mode? Which age group?
Sometimes between age 12 to 18.
What is that?
young adults.
Yeah, what is the age group? You can roughly say.
12 to 24.
Yeah, 24. Is it 24 right?
20.
You see, you'll be getting marks, okay. Shyam, one more point, mark, Shyam. So, you see, that is because you do not think about that. You see, tumor is a abnormal growth. Abnormal growth occurs only when there is growth. When there is increased growth, there is, don't study that GCT, this much, there is explanation. There is explanation. So, it is the adolescent growth spurt. When there is an adolescent growth spurt, that is the time when there is maximum growth. If only there is growth, there will be abnormal growth. So there is no hesitation. Once the epiphysis closes, then there cannot be any osteosarcoma. And again, without closure of the epiphysis, GCT is uncommon. It's not natural. So there is no confusion regarding the age. It is 13 to 21. This is adolescent growth spurt. That is the answer. Or you can say 10 to 18 or something like that. Even if it's 12 to 17, does not matter. So this is a very fundamental thing. Don't remember all the age groups. This is all scientific. Unfortunately, the orthopedic surgeon did not identify the lesion. So I want to teach the budding orthopedic surgeons that don't miss such very serious things. So you may at times you may miss it. So don't miss such very serious things. It is not very striking, but don't miss that. So that is orthopedic surgeon missed that, and it continues to grow. And it thigh is swollen, and only he understood the mistake when he took the X-ray. And everybody has written the tumor is winning over the body's defense. Everybody wins. There is no doubt. Radiation is healing just for change. I have written, that's all. So soft tissue extension that happened during this period mimics the periosteal reaction. So periosteal reaction is destroyed by the soft tissue extension. Soft tissue extension means that the tumor is growing leaps and bounds. That is the reason. Blood investigation normal except increased ILB. How will you proceed? Everybody has written MRI because before biopsy you have to take a MRI. That is fundamental, very fundamental. But bone scan only after the biopsy. And this is a T1 weight images. Everybody is written. Everybody know it is T1 weight images. And T2 weight images this here. How will you proceed? Obviously, everybody by that time know it is CT guided biopsy. And there is confusion. Somebody has written, you see, CT guided biopsy is something. That is what happens is that when I get a referred case, I will be doing all the same day. I will be asking for the blood investigations, but soon I will be informing the sister in charge to arrange for CT guided biopsy, and in the afternoon itself, I will be doing the. I will not be admitting. I will be doing the CT guided biopsy in the afternoon, 2:30. That's the time, and I will be sending the patient back home. So this is not done under anesthesia. This is a simple procedure, OP procedure. Costs about 5,000 rupees. That's all, along with the CT. And this is a CT biopsy done. There are a lot of things to be told about this, but as we have one or two cases more. So this highlights, you should not, I have written, biopsy.
This is, it's mainly a pink color that's predominant. So you have pale pink areas which are devoid of any cells. Those filigree-like or fern-like thin areas show that it can be osteoid. And then you look at the cells which are surrounding those pink areas. Those are not very small. They are sort of intermediate in size and show some pleomorphism. Pleomorphism meaning there is variation in the cell size, the nuclear size, etc. So that means that this is a malignant neoplasm for us, and because that osteoid is also identified, we would label this as osteogenic sarcoma, conventional type. It's again a higher power view which shows the same material, but here more than the osteoid, it's the cells that are predominant. It's a very cellular area. You can see some cells which are rounded, others are more spindly in nature.
So the following is the close histological differential diagnosis.
The answer to this should be callus.
Yeah.
I don't know what has come up.
It is also sarcoma only.
No, the differential diagnosis should be callus.
So majority has written callus, right? I think there is no confusion because very much these are all pneumo formation that is taking place, and myeloma it's okay. So majority, almost always there is no confusion seems, and naturally it is osteosarcoma. How will you proceed? And the question, what is the answer? So this is the way we proceed. That is CT chest and the technician scan. That is and PET scan is not. PET scan gives more information, but that is not necessary because it's a bone forming tumor. It is well seen in the bone scan because bone scan show the osteoblastic activity, while the PET scan is for I think Binu Alex can answer. PET scan is for Binu Alex. Are you available?
Any widespread metastasis?
No. Those are questions. And I told you, technician bone scan is for finding the osteoblastic activity, and PET scan is for what? PET scan indicate what in general?
Any abnormal cells in the any spread in the other areas?
No. The answer is it is a measure of metabolic activity. That is the answer. So bone scan is a measure of osteoblastic activity. So in osteosarcoma that is very important. While PET scan, it is wherever there is metabolic activity. So have you seen a PET scan where you can see activities in the brain always, because even if you are during scan also brain is acting, but so it did not specify anything. If there is increased metabolic activity, that is when there is increased uptake of glucose, that is it is a fluorinated glucose. So when there is increased uptake of glucose, that means there is increased metabolic activity. So it is not at all specific for osteosarcoma. You may think it is a better scan. No, bone scan is the idea. So that is about that. So you have to proceed with the CT chest and Now there was no metastasis. Patient sent for neoadjuvant chemotherapy. Patient was to undergo surgery after. So there are many wrong answers. This is the standard. So those who are not working in cancer hospital may not be used to that. So I will not say. We do the surgery in between the chemotherapy. There must be, because if at all there is some micrometastasis that is occurring during surgery, the chemotherapy will take care. Not after the sixth cycle. Many have written sixth cycle. That's the last cycle. That's only 6 cycles. And if you are doing surgery after that, naturally there can be metastasis due to by the surgery itself. So 3rd cycle, you may be giving it 2nd or 4th. So that is the answer.
Do you understand what is meant by neoadjuvant? That answer itself, the question itself, neoadjuvant means you are giving chemotherapy before and after.
There must be some chemotherapy.
Okay.
Yeah.
The other one is called adjuvant.
Adjuvant is after.
Neoadjuvant chemotherapy has got 3 uses. I will quickly tell that. That is, one is therapeutic, diagnostic, and prognostic. You can read about that.
Okay. So resection lung during limb length is the surgery is I think many has because this is standard.
This has been told in the treatment part.
So, not on the, this is exactly what the answer is. That is 3 centimeter proximal involvement T1, not T2. Because, Binu, can you tell why it is T1? That is, Binu Alex? Yeah. Yes. What is the reason we call it as T1, not T2? Can you tell that?
T2, I think the edema and all will be picked up in T2.
Yeah, that is exactly the answer. The marrow involvements will be clearly seen in T1. So, Binu get 1 mark in T1. But T2, it is all the inflammation will be picked up. So, that is not an exact line. So, T1 before chemo, that is the standard way. And at this stage, option for reconstruction include all except what is it done? Orthodosis, standard modular processes is the answer because Raphael, can you say why standard modular process is a failure in this case? Raphael Thomas, can you say?
It's a 6-year-old child. Sir.
Yeah. So if you put a modular processes, what happens?
We need for revision.
Yeah. As the child grows, the limb become shorter because we are taking away the growth plate also in the distal femur. So Raphael gets 1 mark. Orthodosis can be done in children also, and I have one case which is done orthodosis later. We did everything settles. We did irisaro lengthening. So it is not it can be done. But rotationplasty is something which is of my favorite. Then favorite surgery which I have done a few regarding the rotationplasty floral statement is correct except. The entire involved segments from the skin to bone is removed and masked except femoral vessel and sciatic nerve. So chance of occurrence is actually that is the correct answer. I mean it is a correct statement, and because you get good clearance, it is as good as amputation. Another specimen the padam kanikkan vittu ee question engane tettu pattunnu njan vicharichilla. Adayathu we'll be removing the entire skin and muscles, everything. And only the sciatic nerve when they are, I think, Dr. Dijo has shown it. And it is not at all ideal for elderly, not at all ideal. So it's for children, it is for children, this patient, this is the ideal patient. Showing some of the rotationplasty cases which, you have seen that in my, in that case itself, so I am not repeating that. Some of the cases which I have done, you might have gone through that, I hope. And this is the video, video of the first patient, how beautifully he walks. So here's the first patient, and I used to say that looking at him, he is the leader of about 10 patients. That is why he walks like a leader. We're proud of that, it seems. Next one. That is how he climbs the stairs. How he climbs the stairs. Yeah, you do it without any effort, without any support. It works as if he is normal. You can see the heel is projecting like the patella. The heel that is seen. It is actually the, that's so, and this is another case. So he forgot to bend that. So unlock it, then start walking. So you can, This is how the movement is. The angle joints acts as a knee joint. The angle joint is actually just an angle joint. You can see here, there regains very good movement of the knee. So it's a very rewarding surgery. So now coming to the next case. 8-year-old is already you have seen discussed. So let us come to the questions. Which of the following statement is correct? I think I just gave a very too simple a question, and everybody has promptly answered. It looks a foolish question. Not. Yeah, because everybody has. I don't confusion like it. Everybody has done it correctly. Just make sure that you are not watching. Yeah. Aggressive lesion or the rise is evidenced by the following except.
Classification answer.
Flocculant calcification is the answer.
Some certain white zone of transition.
Yeah. So white zone of transition means there should not be any. You cannot. There is white zone of transition because there is no margin. You cannot say where it ends. We cannot say where exactly is the. And you can see the soft tissue extension here. So there is no flocculant classification that can occur in which condition you occur it? Flocculant calcification? Anybody? In the cartilage. When there is cartilage, so there is nothing to do with the cartilage. So it is there is soft tissue extension. There is margins are not at all well defined. You cannot say we cannot say whether it is here or there. So everything fits into an aggressive lesion, and this is the investigation result. And what is the most possible diagnosis? You cannot clearly say it can very well be. What is the answer? Tuberculosis involves the joints, as we have discussed in the other tuberculosis case. It affects the joints rather than the body, rather than the shaft. So, in this case, the joint is well preserved. You can see the joint is well preserved. There is no joint space narrowing. Joint is well preserved. This is the lack of clarity is because of the radiological changes occurring. Over here, it is quite clear. So, joint is preserved. So, that itself you can say it is not unlikely to be tuberculosis. So, somebody has written tuberculosis. Osteosarcoma, we cannot rule out. What is the age of the patient is?
8 years.
8 years. Again, it is not that of age is not in favor of osteosarcoma. It is more in favor of weavings. But except for that, and there is no periosteal reaction, laminar, all these things are not there. But there is nothing wrong if you say osteosarcoma as a second possibility. How will you proceed? MRI. Everybody has written MRI because you have to do MRI before biopsy. The reason MRI is to be done before surgery is the following except. Yeah. Everybody has written correctly. The MRI pinpoints the diagnosis. As I already told, MRI hardly help in diagnosis. We have already a discussion. A situation where MRI really helps in diagnosis. Raphael, can you tell? In the morning we had a discussion where MRI really helps in diagnosis. This one specific condition. That is the exception we already had. Raphael, Thomas, can you tell?
You will be looking for fluid.
Yeah.
Evings. In Evings?
No. My question is in Evings what happens?
MRI can be used for diagnosis.
No.
And also in hallucinatory granuloma like lesions.
No. So, Shyam, can you say? We are all, sorry, Shyam, yeah.
Electric fluid level.
Which stage is? Aneurysmal bone cyst. Aneurysmal bone cyst or simple bone cyst?
Aneurysmal fluid level.
Aneurysmal bone cyst. Why there is fluid level? Because in simple bone cyst only clear fluid, while in aneurysmal bone cyst it is blood also. So just like that happens in ESR pipette, the Buffy coat comes down. That is the packed cell comes down and the fluid remains. So the same phenomenon. So in simple bones there is no blood. So it is occur only in aneurysmal bones. So that is a shunt at one point. That is a exception where MRI pinpoints the diagnosis. By and large, MRI is not helpful in diagnosis. It is meant for planning the surgery. And I made a very simple question, and everybody has answered naturally. It's a foolish question. Okay, so I'm not answering that. This statement is correct regarding the image of the patient.
Many prefer it is a soft tissue tumor from pelvis rolling the bone.
Yeah, so you can say, you can trace the bone, and it is not something rolling. You can trace the bone from above and below, and it is from the bone only. You can see it is continuation of this floral acetabulum going like this. And I don't know why people are thinking something rolling. It is a bone lesion with a prominent soft tissue extension, no doubt about that. And it is a T1 image. I think it is clear. Does it require any any explanation?
No.
Yeah. Okay. No. What next? Everybody has imbibed the idea of CD-guided biopsy by now, it seems. So there is no question of any other ultrasound biopsy is not for the bone. And this is how we took the CD-guided biopsy. And the wrong statement, image above is to plan the entry point, image below is to check the position of the needle. Here the biopsy is planned so as to take the specimen of the soft tissue common in the lesion. Biopsy was done by the radiologist. And
wrong statement.
Yeah, so
many has preferred C.
Yeah, and C.
B ആണ് correct.
So actually, radiologists are also doing that, but we orthopedic oncologists always tells that just be done by a person who do the definite surgery. So we always prefer to be done by us or one of our teammates. Radiologists may not be knowing about the definite surgery. So there is some controversy, but still we strongly feels, the orthopedic oncologist strongly feels it has to be done by the surgeon himself or one of his teammates. If at all the radiologist is doing, he must consult the orthopedic oncologist regarding the approach and all. So if they are doing in consultation, there is something wrong. Now coming to the biopsy.
The biopsy here, what you see under this low power is you can see sheets of blue cells and they are separated by a fibrous stroma. So what you see in blue is the sheets of blue cells, the round cells. Next power now. It's arranged in sheets, and this is the high power view where you can see small round cells with scanty cytoplasm, large round nuclei. Some of them will show prominent nucleoli, and it's arranged in sheets. So just with that morphology, we might just give you a report of a malignant round cell neoplasm. Very often, one of the history is very clinching where the orthopedician would tell you that they might have got pus during the procedure. So after this particular morphology, if you have a differential, if you're thinking of a malignant round cell neoplasm and you have Ewing's in mind, you can do a special stain, PA, as in the morning Dr. Deepti had mentioned, and you can clearly see the magenta color, the pink color that's taken up. The cells have glycogen in their cytoplasm, due to which you can have this particular pink color material is seen, favoring a diagnosis of Ewing's sarcoma. Now, the next thing that you can do is you can go ahead with IHC. The marker that we have in our institute is CD99, which gives which stains the cytoplasm of the membrane of the cells, of the tumor cells. So CD99 is positive here, but there's a more specific and more sensitive marker, that is FLI1, that is very specific for Ewing's sarcoma. So the morphology along with the special stain and the CD99 clinches the diagnosis along with the clinical and the radiology clinches the diagnosis of Ewing sarcoma. Since I've mentioned that it is a malignant round cell neoplasm, just like we said in the morning, we need to rule out other round cell neoplasms. So we put in a CK, that is cytokeratin, and CD45, that is LCA. Both were negative, which rules out a carcinoma or a lymphoma.
So what is the
diagnosis? Is Ewing sarcoma.
No. So there is so evidence written Ewing sarcoma. So as Dr. Srija was telling, it may be the orthopedic surgeon or the surgeon will be saying it is pus. So I have in my X-ray discussion, I have shown a case which was diagnosed as osteomyelitis only. Everything fits into diagnosis osteomyelitis, but it did not respond to antibiotic. So even when we opened, I don't know whether you remember that X-ray of the say 7-year-old boy. When we opened, we made a opening in the radius, it is in the radius, and a drop of pus came out. So even then, that told me it is osteomyelitis, and on biopsy, it was Ewing sarcoma, because we suspected that because it is not responding to chemotherapy, but perioperatively also there is pus. So that is why I said when you get a pus, you have to send for biopsy, and when you when you take biopsy, you take for culture. That's why. And I have case, I still remember a case. There is a tumor. When I open it, is real pus only, and I told them about say 5 or 6 cc or more than that, it seems. And I was told, oh, it is only pus only. But next day I entered the pathology department with the hope that to make sure this is everything. Then they said it is not like that. They showed the slide to me. So I have to take back the words and say the sad situation of small round cell neoplasm. And I think, I don't remember, she is no more, that's what I remember. Now coming to the new case in the that is a 7-year-old female, pain right hip and limbing. Possible diagnosis include all except, I think, Shaiju. Shaiju is there? No. Shaiju has left, it seems. I think Shaiju is not there. Okay. So, Binu, what is the answer? I shall show the X-ray again. Yeah. This is 70-year-old female, that is important. And you think about once again, because this 70-year-old female, and can you locate the lesion? Where is the lesion first? Where is the lesion? You compare the both sides, and only you will remember. It is not in the femur. It is not in the femur, after all. So you located the lesion. Then you answer. All except. So the correct answer is simple bones. You told us the.
Except.
Yeah. Simple bones. Simple bones. It is not a case of.
Simple bones.
This is not a case of simple bones.
Where is the lesion?
It's in the floor of the developed floor.
Okay, not in the floor, in the junction of in the pubic bone. Actually, it is in the pubic bone. Okay, so it is in the lateral aspect of the pubic bone. Okay. Now, the skeletal survey show this picture, and I think Raphael, you can answer.
Can you show us the lesion in the pubic?
Raphael? No, what is the appearance known as? The classical of something. Not the diagnosis. This lesion is described as this. very classical appearance. Okay, if you are not answering, Sham, Anand.
Sir, it is a functional.
Okay, anyway, Raphael will be getting the marks. Okay, Raphael, punch out lesions. And Raphael has to say in which condition you get it. Raphael, anyway, you get 1 mark. So now what is your diagnosis? So diagnosis is very obvious. There is no, because the multiple myeloma I already told. So it's a multiple myeloma. What simple investigation will help you to reach the diagnosis? I think Sham now can answer. Sham.
Sir, I think for Bellstone's protein.
Okay, yeah.
Investigation.
Yeah. Anyway, you can say what happened. Alkaline phosphatase. What about the myeloma and alkaline phosphatase? Usually, is it elevated or not? Usually, Sham can answer.
It is elevated.
No. So, Bellstone's protein. Where do you detect Bellstone's protein? Sham can again answer.
So we do it in urine samples.
Urine samples. Okay. So interestingly, I have not seen a single case of Bellstone's protein positive. So this is something that we learn in biochemistry, and it is not been. I think no, it is not seen. That is all. So the answer will be then. What will be the answer? What is more specific investigation? More specific.
Specific, we go for serum electrophoresis.
Electrophoresis. So that will be. Anyway, Sham will be getting 1 mark. That is serum electrophoresis pinpoints the diagnosis. And what do you see in serum electrophoresis in myeloma? Yamband. Okay. So in this patient, serum electrophoresis did not show Yamband. That's the problem. So if it is positive, I would have avoided even a biopsy because everything fits into. Because punctured lesions are so typical. So there are cases where Yamband need not be. There are other proteins which is like kappa, lambda, what is that?
Kappa, lambda, light chains.
Light chains, other light chains are there, which is, it need not always be myeloma protein. So there are many cases which are myelomas, but Yamband negative is a possibility. But if it is positive, then it's a strong point against, in favor. But that is alone will not be. So we have to go for a biopsy. So that is how you do that. You have to avoid the vessels very nearby. There you can see the vessel. This is the vessels. You can see from the round appearance. You can avoid the bladder, all these things. So you have to be very careful. Know about the structures, but otherwise it's okay. So just CT biopsy was done, and you can do.
In myeloma, the neoplastic cells are called as plasma cells, and they show the characteristic picture like nucleus is pushed to one end, that is the eccentrically placed nucleus, and the cytoplasm is pushed to the other end, just like this. Like this cell. The nucleus is towards down and the cytoplasm is towards the other end. The nucleus shows the characteristic chromatin pattern, that is either called as a clock face nuclei or the cartwheel nuclei. There is a chromatin is clumped at the periphery of the nuclear membrane, and that is a characteristic plasma cell. So you will be seeing sheets of plasma cells, can be either mature or immature. This is another picture showing sheets of plasma cells. These immature plasma cells will show a prominent nucleoli. And the important feature of these plasma cells are we can do IHC on that. They are CD138 positive, MOM1 positive, and they will be showing either kappa or lambda, and that is called as kappa or lambda restriction. So if it is a monoclonal tumor, that is in myeloma or any other plasma cell neoplasm, they will show a restriction. If it is an inflammatory collection of plasma cells, they will be showing a mixture of kappa and lambda positive cells. That is, it is polyclonal.
Following are the important investigations in the condition except everybody is filter. If you're calling something to do myeloma. Now, there is one case, known case, it is a known case of CA thyroid and complaining of pain in the left iliac fossa. Is the Shaiju available? No. Shaiju? No. So, goes to Binu Alex again. There are two lesions, I shall show you. This is one and this is second. Which you think is significant?
The red one might be
the you think it is relevant, or the other one?
The thyroid, I think, is a lighting lesion, so the red one will be.
But will there be anything else there? You just trace the.
Gas shadow.
This gas shadow. Anyway, yeah. So this one is this is what, because you see many times we presume everything as gas shadow. That is what is happening. Gas shadow can you have to trace that. On the lateral aspect, this lesion is not gas shadow. This lesion is gas shadow, and this is not gas shadow. And so this pain, that may be the cause for the pain. And this was sent for biopsy, and Binu can again tell us what is the pink material seen in this slide? What is the pink material seen on this slide? You can answer. This is the answer. Is it osteoid or colloid?
Osteoid.
You see, after all, it is a thyroid secondary. Am I right?
Yes.
Okay. So it's colloid only.
Actually, for the pathologist, this is a representation of how you see the normal thyroid. It's just closely packed follicles. One of it is dilated, and that dilated one shows that pink material inside, which correctly said it's colloid. And if you look at the lining around that pink material, you are seeing cuboidal cells having an oval sort of uniform nuclei, which is always seen in thyroid malignancies. So it's a metastasis from the thyroid. If at all there is no colloid, supposedly your field that you're looking at doesn't show colloid, it's only closely packed cells. You have a history of a thyroid surgery prior. You can do a immunohistochemistry. Thyroglobulin is one of the specific markers available that will stain positive. Here it's not needed.
Now I have, I thought if there is a lot of time left, I thought of a discussion on metastasis, because metastasis is something, so I shall ask Minu again, because he has not given the right answer. What is the commonest, which has already been given, but one more question. What is the commonest malignant lesions of the bone? What is the most common malignant lesions of the bone? That has already been given in the secondaries. Again, what are the manifestations? What are the symptoms or manifestations of secondaries? You must say at least three.
Pain, loss of weight.
No, it's not specific. What type of pain? What type of pain? Bone pains. Okay, then what else? Loss of weight is not specific. That's specific for metastasis in the bone. Now, Binu has to answer.
Pathological fracture.
Yeah, pathological fracture is the answer. Yeah, then what else? No, you are not allowed to answer, because this is actually it's a final round where the first prize decision. So don't answer in between. Okay. And now I think Raphael can answer.
Sir, bone pain,
Yeah, then.
fracture,
Hypercalcemia. Anyway, Raphael and Binu gets half mark each. Hypercalcemia. And cord compression is the fourth one. Because what is the commonest site of metastasis? Commonest site of spine. So naturally, cord compression is a quite common complication of metastasis. Now, what is the commonest primary that produces metastasis in the bone in females? Sham. In females, the commonest primary breast. That's right. Yeah. Only those who are because we are planning to decide the who is winning the 2000. So don't mix up. So Sham will be it's already given. So Sham will be getting 1 mark. Then Shaiju is not here. So Binu again. Which is the commonest primary in males to produce secondaries in the bone? Binu. Prostate. Actually, they both are. What else? One more, because it's so equal number. Yeah, prostate along with lungs. Lungs. You are right. So Binu gets 1 more mark. So that is about that. Then Raphael. What is the other 2? We have already told 3. Then what comes in 4th and 5th?
Thyroid.
Then 5th.
Liver.
No. Anyway, Shyam.
Thyroid follicular cancer.
Renal carcinoma.
Renal carcinoma. So that comes 5th. So I think Raphael and Shyam gets half mark each. So Shyam will be 1 more question. What is there in common with thyroid and kidney primary in the bone? When it produces metastasis in the bone, there are 2 features that are common to kidney and thyroid.
They cause osteolytic lesions.
No, that is not the answer.
Like that.
Can Binu answer?
Is it lighting and vascular, please?
It is vascular. Both are very vascular. And is there any other thing? In general, they are slow growing. Okay. I think Binu has to get 1 more question. That is, now I thought to have a long discussion because I thought by that time there will be enough time. But now there is not much time. So we come to the next case, which you have already seen. So I am not going to read it. This case and the striking points like that. And at this stage, the least possible diagnosis is what is written. So you can see when the elderly patient coming with the increased alkaline phosphatase, we have to think of what? Secondary. That is right. Then what else? Shall we consider multiple myeloma? Anybody can answer. This is not a question. Shall we consider multiple myeloma when there is increased alkaline phosphatase? Because we all know. So what is that? Pagers is a possibility. That's all. Yeah, that's a possibility. And these are the findings. There are some lesions here and there. And there is nothing abnormal over here, it seems. And this is a MRI finding. So, and it shows the prostate. There is a, you already read it. And prostate is enlarged. So, naturally, which further blood investigation you think will take the diagnosis? Everybody is written, because many has written serum electrophoresis. I think we know the answer. Why serum electrophoresis is not important in this case? PSA is the right answer. Why serum electrophoresis, as written by some many candidates, is not the correct answer?
Because this is neurotic. lesions.
So you do not.
And the alkaline perspective
Very high.
level is raised.
So
yes, there.
So-
So ESL can be the goal of secondaries from prostate.
yeah, that is PSA. Why not electrophoresis? That is the question. Why not electrophoresis? PSA is the right. That is that is.
Then sclerotic
So-
lesions and no multiple functional lesions.
So it is unlikely to be
Multiple myeloma.
multiple myeloma. That's the question. Anyway, Vinu will be getting one more point. And this is the investigation which so PSA is normal. We are suspecting prostate secondaries definitely, but contrary to our expectation, PSA was normal. So we are come with the most probable diagnosis. What is written?
Metastatic.
Paget's is the right answer, but metastatic bone disease, the sclerotic secondaries are produced by, I think Raphael can answer. Sclerotic secondaries are typical of Raphael. Sclerotic secondaries are typical of Raphael. Raphael not available. Yeah, Raphael, sclerotic secondaries are typical of
multiple myeloma.
Okay, Shyam.
Sir, CLM.
Sclerotic secondaries are typical of
CLM.
Produces slight one.
we know sclerotic secondaries are typical of
Is prostate and
prostate. So we know get it's typical of prostate. So when you get the sclerotic secondary, it is prostate, no doubt. So we know we'll be getting 1 mark, and this badges. In this case, the most possible because metastatic bone disease is a possibility, but as PSA is negative, then possibility changes. So that is why many have written metastasis because of the increased alkaline phosphatase. But the commonest cause reaction producing sclerotic secondary is out because PSA is normal. That is why patches become the possibility. While you proceed, what is written? Core biopsy. So we have to go for core biopsy. PET scan can be done. PET scan can be done. What is the advantage of doing PET scan in such a scenario, Raphael?
Occult primary, we can find the occult primary.
We had a provisional diagnosis of Paget's now. In that situation, in that scenario, in what way the PET scan help?
Increase uptake.
Indicate?
We see where the most metabolically active cells are.
So that will help in anyway, I am not giving marks because you are not specific. And so that will help you to take core biopsy from the exact position. So you see, though not an absolute indication, PET scan is ideal as it will give an idea about the most active site. So this is the most, you can see the PET scan and you can identify from where we can take biopsy. If you are taking a biopsy from a less active site, then you may not come with the diagnosis. PET scan report, and so I saw the PET scan report and took the biopsy from a very active site. So that is the advantage of taking PET scan, and we get this is the picture.
The main pathology in Paget's disease is there is an increased osteoblastic activity and an increased osteoclastic activity. That means you will be seeing thick, wide and bony trabeculae like this, and thin disconnected bony trabeculae like this. And because of the increased osteoclastic activity, you will be seeing plenty of osteoclastic giant cells like these. These are the osteoclastic giant cells, and the increased osteoblastic activity is denoted by the increased number of osteoblasts rimming the bony trabeculae. Another important feature which you have to see in Paget's disease is the cement lines. These are the cement lines, blue lines which are irregular in the on the sides of the lamella bone. So these cement lines will give a mosaic appearance. And so this is the picture of Paget's disease. Thick and thin bony trabeculae and cement lines giving a mosaic pattern. These are the osteoclastic giant cells, and these are the cement lines. This is the normal lamella bone, and on these, when the new bone gets deposited, they will produce the cement lines like this.
So, Paget's is it the common here because the mass things are settled, so we can have a light discussion, only 3 or 4. So, is it very common? Paget's here, Paget's common here. What do you feel, Rafael? Is it common? It's considered as a disease of the Englishman. And those who used to tell the commonest complaint is the size of the hatch increases. The hatch does not suit. It become this become bigger and bigger. That is the thing. And as Shyam has in between told, it's the so-called bimodal of the osteosarcoma, which is classical teaching, is not at all applicable in our country. But I have come across the less than 10 cases of Paget's in my life. And interestingly, 2 of them was osteosarcoma. So, Paget's turning osteosarcoma is not uncommon. But as the incidence of Paget's is very, very low in our area, it is better to not consider the bimodal and all in our country. But I think even in comparison with the rest of the Europe, Britain has got, UK has got the maximum number of Paget's. That's what I understand. That is about the Paget's. And
what is the pathology in Paget's? Who is at fault? How is it produced? Shyam can answer.
Is it osteoblast or osteoblast?
So you should know what the pathology is.
There are around 3 stages of
No. The question is very specific. Especially in the exam, when you are asked a specific question, the answer should be to that question. Anybody can answer. Joseph can answer.
Joseph John, you are not answered so far. Are you available? We have no idea. In the morning, I have seen you in live, but later.
Sanju can answer. Jodhimai.
Yeah, there are few people who has appeared in the screen. That's all. It seems that they are not attending. Anyway,
so it is disease of osteoclast. So the osteoclast become abnormally active. It results in increased bone resorption and formation of abnormal new bone. New bone is formed, but the new bone formed is abnormal. So it goes through 3 phases, and there are different etiologies proposed. And one interesting pathology is reason for the etiology is. Can anybody tell, Binu? Can it be an infection?
Can any viral infection produce Paget disease?
Which Paramyxovirus, yes. So paramyxovirus.
Canine distemper virus, paramyx virus.
This already described.
How is this metastasis? Okay.
So we have some PowerPoint presentation about that. Dr. Abhilashi has prepared, and you might have gone through that. I hope. And this is about the budgets. Leading to theology. These are all mutations, viral diseases. Paramyxovirus is the.
An example for paramyxovirus is a canine distemper virus, which causes rhinitis-like symptoms in dog. So it was proposed that dog owners of UK has most of this Paget disease, but it's only a hypothesis. No viral inclusion particles has been identified in the Pagetic cells.
So this is tells about the pathology, pathogenesis of.
If you would like to remember one pathway in orthopedics, you should be remembering the rank-rangle pathway. Rank-rangle pathway. Most of the things in orthopedics can be explained using this pathway. So the rankle is produced by the osteoclast, and you have got a receptor in the osteoclast, and that rankle will be getting attached to the rank, and that will be activating the osteoclast and making it into a active osteoclast, which is a multinucleated giant cell sitting on a Fauci blockade. So it will be destroying the bone, organic and inorganic, through two different pathways. So a lot of drugs are acting. You have got denosumab, then you have got romosozumab, then you have got odonacatib, then bisphosphonates. So you should remember this pathway.
So there are three phases, lytic and all. So this has already been given to you. So there is no mosaic pattern.
In the phases, you can see that the lytic phase is the first one. So osteoclast is the culprit cell that begins the process. Okay. So the first phase is the lytic phase. That is actually promoted by the osteoclast.
So this is a Bream sign they are sending. Anyway, these are all these are things which Dr. Abhilash has made a PowerPoint presentation, which you have already seen. So I am not going through that. So I think that come to our end of our CME.